Good morning, everyone. So, are we having here Dr. Madhusudan? Okay, good. So, to begin with, for this PG competitive paper session, I would like to invite our chairpersons, Dr. Sandeep Kumar, sir, please, and Dr. Sudhir Kumar, sir, please. And the first paper will be presented by Dr. Madhusudan Kumar on outcome analysis of retrograde nailing and plating in the distal femoral fracture, a retrospective analysis of 30 patients. Dr. Madhusudan. So, Rajiv, Pragya is, where is Pragya? Where is Pragya? Madhusudan.
Dr. Madhusudan to start with. Kindly stick with the time. This is highly mandatory.
Okay, sir.
And presentation time is for the 6 minutes. टाइमर 6 मिनट पर डाल दीजिए. डॉक्टर राजीव पेन चाहिए.
Good morning, everyone. Introduction. Distal femur fracture represent about 6% of all fractures in femur. It's noticed that there is bimodal distribution fracture based on age and gender. In this retrospective study, we evaluated and compared functional outcomes of distal femur fracture stabilizing using retrograde nailing and plating. The incidence of fracture is highest in people older than 60 years and age group of 15 and 24 years. Available implants for fixation of these fractures with above mentioned principles are fixed angle blade plate, condylar buttress plate, dynamic condylar screw, cancellous screw, distal femoral locking plate, retrograde interlocking nail, and antegrade interlocking nail. To compare the results of modes of internal fixation of distal femur fractures by distal femoral nail and distal femoral locked plate. Objectives: to compare functional outcomes of fractures of distal femur operated with distal femur locking compression plate and distal femur nail using HSS knee scores. Materials and method. In this retrospective study, which was studied between 2021 and 2023, 30 patients with distal femoral fractures who had been treated by retrograde nailing, total 15 patients were studied, and plating 15 patients were evaluated in this study at our center. X-rays of all fractures with CT scans of AO type C distal femoral fractures were done. The choice of implant for definitive osteosynthesis was dependent on the fracture's type, quality of bone, and local skin conditions. Inclusion criteria were patients of age group 17 and 85 years, all patients with closed displaced fractures of distal femur, open fractures of Gustello-Anderson classification type 1, type 2, and type 3, patients willing for surgery. And our exclusion criteria were Gustello-Anderson type 3B, 3C, pathological fractures, associated neurovascular injury, and crush injury. Gustello-Anderson classification, we already know, clean wound is less than 1, type 2 is lacerated wound more than 1 and less than 10 centimeter, and open, type 3 is open segmented fractures. It is further classified into 3A, 3B, 3C. And this is AO classification of distal femur fractures. Type 1 is extra-articular, type B is partial articular, and type C is complete articular. Our The hospital for special surgery score is used to evaluate the functional outcomes of our study. This is case 1. In this, the spiral fractures were fixed with open reduction and internal fixation with plate. And this case 2, this oblique fracture is fixed with open reduction and internal fixation with plate. And this transverse fracture is fixed with ORIP and plating. And this spiral fracture is fixed with DFN, distal femoral nailing. And this transverse fracture is again fixed with DFN. Discussion. Neradi in their review article opined that surgical duration and blood loss favored plating groups. And while analyzing parameters like implant failure, knee range of motion, non-union and union time, our analysis favored nailing group, but the difference is not significant. How in their study in clinical outcomes largely depends on surgical technique rather than on the choice of implant. Therefore, correct rules, the same for every procedure, should be strictly adhered to, especially in the application of locking plates. Roger, in their study, calculated that locking plating may be utilized for all distal femur fractures, including complex type C fractures, periprostatic fractures, as well as osteoporotic fractures. IM nailing may provide favorable IM stability, may promote formation of circular and stable callus, and may be successfully implanted in bilateral or multi-segmental fractures of lower extremity, as well as in extra-articular and type C1 fractures. However, both systems require precise preoperative planning and advanced surgical experience to reduce the risk of revision surgery. Clinical outcomes may largely depend on surgical technique and rather than on the choice of implant. The clinical and radiographic evaluation demonstrated average time of union in plating 6 months, and retrograde nailing group was 8 months. In the retrograde nailing group, 3 out of 30, approx 10% developed non-union, as no bony consolidation of femoral fracture was observed 9 months after fixation. In the plating groups, non-union was observed in 2 out of 30, approx 6%. The mean HS score in the plating and retrograde nailing are respectively 90 and 86. Hero Holzer in their study concluded that lock plate may be utilized for distal femur fracture, including complex types. Our HSC score is excellent in 8 in retrograde nailing, 10 in plating, and good in 5 in retrograde nailing, and 3 in plating. Fair in retrograde nailing is 2, and in plating 2. Conclusion: both retrograde nailing and plating may be adequate treatment options for distal femur fractures. No difference between implants regarding fracture healing, non-union were found, but the plating group had better outcomes at 1 year's follow-up. Retrograde nailing may provide favorable intramedullary stability and stable callus, and may be successfully implanted in bilateral or segmental fractures of the lower extremity. Persistent knee pain and inability to use in type C fractures are the main limiting factors of the retrograde nailing. In type A fracture, plating was associated with less morbidity in terms of persistent knee pain and better range movement. At 2 years of follow-up, then retrograde nailing, locked plate may be utilized for all distal femur fractures, including complex type C fractures and osteoporotic fractures. Clinical outcomes may largely depend on surgical technique and fracture pattern rather than on the choice of implant. Also, no two fracture types are same. Multi-center studies with high number of patients are required to draw useful conclusions. Thank you.
Yeah, doctor, you have shown the X-ray. Some of the X-ray was not showing even the reduction, like interlocking. All the X-ray you have shown in the metaphyseal end of the fractures. So how do you compare the, how have you said it's a distal end of the femur? Have you included any cases with the intra-articular fractures?
No, sir.
No. It's a purely metaphyseal or diaphyseal fractures.
Yes.
So how can you compare the two groups of the people without proper reduction, even in the, by doing a open reduction, internal fixation in the nailing group, whatever you've seen as a, shown as a case there was not a acceptable reduction. Neither the length and alignment and rotation was not very well maintained. Okay, thank you very much.
How did you randomize these patients? The age was 17 or 18 to 85.
Yes.
So how did you randomize these patients? किस में nail करना है, किस में plate?
Sir, in young patient we tried for nailing, and in
ये तो बायस हो गया ना बेटा.
yes,
अगर आपने young patient में nail कर दिया और osteoporotic में plate कर दिया, तो how will you compare these two? Bias हटाने के लिए we do randomization.
yes.
So the age is a very, very big range of the age, and there should be no bias. So that should be randomized the study rather than this. Chalo, okay, thank you.
Thank you, sir.
Next बोलाइए.
Dr. Arup Biswas.
Good morning, everyone. Hi, Dr. Arup Biswas, third year junior resident of Goa Medical College. Today's my topic is functional and radiological outcome of thoracolumbar vertebral fracture following fixation using pedicle screw and rod system. Okay. So first, 1963, Holdsworth discovered this thing. Then importance of treatment for restoring stability and preventing further neurological damage is the main important. Aims and objective. Here to study and analyze the radiological and functional outcome following fixation of thoracolumbar fracture using pedicle screw rod system and analyzing with X-ray, kyphotic angle, Beck's index and Dennis Penn score and Roland Morris questionnaire. So this is the materials. Total 25 patients I have taken, 18-month total research period. It is started from January 2021 to June 2022, and surgery was performed mostly between 2 to 4 days, and post-op follow-up I have taken up to 6 months. Inclusion criteria: age 15 to 60, TLX score more than equal to 4, minimum 6 month follow-up. Exclusion criteria is pathological fracture, TLX less than 4, and associated with cervical and sacral level fracture, and patient with head injury also. So this is surgical management. During our study, we use the conventional posterior technique with the midline incision extending towards the immediate caudal and cephalad vertebral level, focusing on the injured level. And technique 1, the junction of a line that runs horizontally through the center of the transverse process, and vertical line that passes through the lateral aspect of the facet is the entrance point of the pedicular screw. Technique 2 is the mammillary process, is nibbled and used as entry point. Entry point confirmed using candle and seen on the C-arm, and after the entry point is made with the starter awl, then the gear stick awl, and is used to enter the pedicle and the body. Tapping is done only in patient with good bone stock. Pedicle breach and length of the screw are assessed using blunt sound. Polyaxial screw inserted, rod contoured and fixed to tulip, and decompression done. Rods connected with transverse connector. So this is the skin incision, exposure and entry making. Then screw insertion and screw fixation with pedicle screw. So this is rod placement and skin closure. Intravenous post-op management. Intravenous antibiotic, third generation cephalosporin and aminoglycoside I have given for 3 days, and then after that maximum case for 2 days. If any infection is there, that time I have given more antibiotic. Physiotherapy done from day 1. Patient are told to start rolling from side to side on day 2. After 3 days of the individual is given permission to sit up straight with the use of brace and begin moving about a wheelchair. Suture is removed between 12 to 14 days. The patient neurological data is recorded, and patient with only minor neurological impairment are gradually reintroduced to walking. Follow-up. Patient are followed up every 4 weeks for the first 6 months after surgery. Patient underwent clinical assessment using Dennis Penn scale and Roland Morris questionnaire, and radiological assessment includes kyphotic angle and the Beck's index. And this is the pain scale. Starting from P1, pain is absent, to P5, severe pain, which is constant in nature, mandating chronic medication. This is the disability questionnaire designed by Roland Morris. Total 24 point is there. This is the result. So total age from 17 to 60, among that maximum is 17 to 25 in this group. Number of patient is 11, And sex distribution, it is 96% in male, and most common mode of injury is fall from height, it is 92%. And this is the type of fracture, level of the fracture, neurological injury. So most common fracture type is compression, and most common level is L1. And neurological injury, incomplete in 72%, complete in 8%, and intact in 20%. Functional score, this is a functional score, functional pain score. So here I got P2, 55% is the maximum. Radiological score, pre-op kyphotic angle was increased, and then after post-op and follow-up it is decreased. And Bake's index is post-op, it is after follow-up Bake's index is maintained. Complication, so urinary tract infection is in 5 cases, bed sore in 2 cases, superficial infection in 1 case, and no case of screw breakage, pull out or connecting rod migration. So this is case number 1, CT and X-ray I showed here. This is the follow-up X-ray. This is clinical picture. This is case number 2. Again CT and post-op X-ray I have showed. Case number 3, case number 4. And summary, since pedicle screw provide the strongest 3-column fixation of the spine, they may be used to treat almost all the spinal fracture with the use of short and long segment fixation. However, there can be incident of malplacement of the screw putting spinal nerve and caught at danger. Conclusion, injured spinal column may have their almost normal architecture and stability restored with posterior stabilization using pedicle screw. Incorporating an intermediate pedicle screw into broken vertebra reinforce the fixation and decrease the chance of failure. Early and adequate stabilization of the decompression yield good functional and radiological outcome. Thank you.
All these patients were without neurological deficit, with neurological deficit, or what was?
Sir, in maximum case it is an incomplete neurological deficit. I showed in that one chart here.
Okay, it was an incomplete.
Incomplete.
ठीक है. Okay, thank you.
Yeah.
Dr. Vidyasagar? He is not here? Okay, Dr. Vidyasagar. Dr. Ayush Kumar Sinha? अच्छा, Dr. Ayush Kumar Sinha? Yes.
Good morning everyone, esteemed chairpersons, guests and dear friends. Today I'll be talking regarding failed subtrochanteric fractures. So we straight away come to the associated factors, which are the unstable fracture pattern, poor bone quality, varus malreduction, improper use of implant, suboptimal positioning of the implant, screw cutout, implant failure and lost follow-up, which leads to either non-union, malunion, severe bone defects, deep infection, articular damage leading to hip arthritis. So management in young patients where there is good bone stock, we try to refix, and in elderly patients who are having associated hip OA, or in the young patients with hip OA, we do a prosthetic replacement. So in reosteosynthesis, we remove the previous implant, debride the fibrous tissue, correct the varus malalignment, fracture compression, larger diameter nail and longer implant, augmenting it with hybrid plate, laterally or anteromedially, and tension cables along with a copious bone grafting. In replacement, we can either do a modular or a hemi-modular or a total hip replacement, additional incision or an extending the previous incision, doing the replacement. After component reduction, we reattach the proximal femur, proximal fracture fragments with the proximal femoral stem, either with cables or plates to get a good tension of the abductors, bone grafting of the non-union using the femoral head, Wagner stems with rough blasting, which bypass the proximal deficient region to achieve a good fixation at the distal femur where there is good bone stock. So complications after replacement can be dislocation, stem subsidence, deep infection, periprosthetic fracture. And after osteosynthesis, it can be either non-union, malunion, repeat surgery, deep infection, etc. So these are some cases. She's a 23-year-old male subtrochanteric fracture communicated. Someone did a short PFN. It was and reduction is also not good. So it failed and it was revised in 2016 with a DHS. And again, the reduction was in varus, but due to the young age, it somehow united. Implant was removed in 2019. 2022, she had a refracture with trivial injury. So we did here a interlocking nail along with bone grafting. Reduction was good, grafting was also good, but still it went to delayed union. Then we dynamized the fracture, and again October it was non-union. So we again revised the implant. We did a long PFN, we chiseled the fracture fragments, put again bone grafting, and a hybrid plate was put anteromedially. So she's at 4 months after the revision surgery. The fracture has very well healed. So another case of a subtrochanter fracture. So it was a old age, 65-year-old male with osteoporotic bone. Fracture geometry was also not very good. So someone did a proper reduction, a longer plate, but don't know about the soft tissue stripping. But at 6 months and 12 months, you can see the fracture has almost in non-union. The screw cutout is there. So we revised it here again with a long PFN and bone grafting. So for 6 months it was good. 9 months it again failed. So we again revised this. During this revision, it was important to hear that we chiseled the intermedial portion of the neck also, so to get a good bleeding bone, and we put a lot of graft intermedially and posteromedially. Medial graft is most important in these cases, and we did the TBW of abductors to maintain the valgus at the fracture. So this is at 5 months, 9 months, and this is at 18 months. The fracture is well united. There is a good callus posteromedially. So this is another case of a failed subtrochanter fracture. Someone did a long PFN, fracture was not reduced, came to us, we removed the implant, we did a plating. Somehow it again failed even after the bone grafting. Again we revised it with long PFN and plate anteromedially. So medially you have to put the plate to get the proper support, because the medial portion is the main thing which is the weight bearing. So 10 months it has completely united. So these were the cases where the hip was preserved. So another case of a 45-year-old medical representative, multiple surgery done elsewhere, came to us with subtrochanter fracture. You can see the hip is also arthritic. So in this patient, we did a long stem total hip arthroplasty. So this is at 1 year. The fracture has very well healed. Patient has gained all his movement, and implant is also sitting very well. So another case, same non-union subtrochanter along with hip OA. So in this also, we did a long stem THR. You can see that we have put the stem little bit higher so that we allow subsidence, so that the patient gets the perfect length after 3 to 4 months. So another 80-year-old male, because the age was at the higher side here, broken implant, we didn't try to preserve the head, we just did a salvage DHA. This is the post-op, this is at 2 months. So in this, we bypass the proximal fragment, get the fitting at the distal end. So there is nothing needed regarding the proximal fragment. It's just that you have to tension the abductors. Another case, same, subtrochanter fracture failed. We did a THA. This is at 1 month. This is at 9 months. Thank you.
Yes, any question from the house?
Yes, sir. I am audible. You are audible, sir. Sir, kindly repeat, sir. I not. Yeah,
spline stem.
yes, sir.
What is the cause of preferring it over, solution?
Sir, it is a kind of solution stem only. It's just that the term Wagner is very much familiar. That's why I'm using the familiar stem, the familiar term. But it is a solution stem which is having edges all around. So, and it's also rough blasted.
Yes, of course, that is good for osteoporotic bone.
Yes, sir.
For osteoporotic bone, that is, of course, very good. But in all cases, even in younger patient, you are using the same.
So it's just that to get a good incorporation with the bone.
That is not the issue. Issue is that everything is tailor-made for something. This is good for this is good for that.
I think most of those patients were 70 or 75 years old, is it?
So the last two cases were around 75 to 80, but there was one case who was 45-year-old male. So
Okay.
in that case also.
So I think 45 years we should try to salvage rather than doing a replacement surgery.
Sir, but in that case the hip was arthritic. He was having no movement at the hip joint.
Oh, I
And
did
on the
not.
X-ray also,
I did not
it was,
see the hip.
Stiff. So that's why we preferred.
So was it because of the fracture, or there was something? Why the
Sir,
hip will get arthritis at the
Yes,
age
sir.
of 45?
The multiple surgeries were done, and even patient developed infection during those multiple surgeries. So it led to hip arthritis. It's a common complication of repeated surgery.
So there was infection as well.
Yeah.
Okay, and many surgeries were done.
Many surgeries were done.
Okay, ठीक है, fine. Thank you. Dr. Avinash Kumar.
Good morning, respected teachers and my colleagues. Today I am presenting a paper on outcome of osteosynthesis and tensor fasciolata muscle pedicle bone graft in neglected femoral neck fracture in adults. The management of displaced femoral neck fracture in young adult is still remains unresolved. Both non-union and vascular necrosis are such complications addressed before even after anatomical reduction and fixation. Head preserving surgery in the need of the time in young adults. Among the head preserving surgery, muscle pedicle bone graft described by Mears and Buxy procedure are very popular. Mears procedure we used quadrilateral femoris, and Buxy procedure we used tensor fasciolata medical bone graft. In this retrospective study, we operated in 15 patients, age between 18 to 50 years with neglected traumatic fracture neck of femur. All were treated first by doing MRI. Then surface section adductor tenotomy was done in all cases. Then femoral head was fixed with closed reduction return fixation with 6.5 cc screw. Then by modifying the Buxy procedure by transfixing TFL muscle pedicle with 3.5 cortical screw in a slot at the subcapital division of the neck of femur to prevent dislodgement of the graft. Post-operative care kept in the rotation boot plaster for 3 weeks, non-bed bearing for 3 to 6 weeks, then partial to full bed bearing were started between 6 to 12 weeks. All the patients were evaluated radiographically and clinically using modified Harris CP score at 3 months, 6 months, 12 months and 24 months. Total cases were study on 15 patients, in which males are 11, females are 4, and 8 have type 3 Garden type 3 classification and 7 have type 4. On the surgical position, on the patient lying on fracture table in supine position, fracture neck of femur reduced and fixation was done in 6.5 cc screw. Hip was exposed using anterior Smith Peterson approach. About 2 into 2 centimeter bone was extracted from the explanatory iliac crest from TFL tied over it, and 3 centimeter thick muscular part of TFL was dissected up to the level of the trochanter. Capsule at subcapital region were exposed, and then 1.5 cm oval window was created using K-wire and osteotome. TFL muscle pedicle bone was then enrooted and turned inferiorly beneath the straight head of the rectus femoris. Then iliac crest bone graft was fixed in the slot created over the subcapital region with 3.5 cortical screw. The hip was closed in layers with a drain kept in situ. In intra-op image of bone graft harvest, case 1, 30 years male having Garden type 3 fracture neck of femur. Pre-op X-ray and immediate post-op X-ray, then follow-up X-ray at 6 months, 1 year and 2 years. Case 2, 19 years male have Garden type 4 fracture neck of femur and immediate post-op X-ray. Result analysis: 7 have delayed union, 4 have coxa vara, and in 4 cases have lateral cutaneous nerve thigh injury. In 3 have transient and 1 have permanent injury. Shortening, 6 have no shortening, and 5 patients have less than 1 centimeter, and 4 patients have more than 1 centimeter. No patient complaint of AVN. Result of modified Harris is evaluated at 3 months, 6 months, 12 months, and 14, 24 months. 8 have excellent scores, 4 have good, 2 have fair, and 1 have poor score. Final follow-up clinical pictures in sitting, squatting position, active straight leg, and hip flexion. It has shown in the literature that the fate of avian is set at the time of injury, and urgent or delay in fixation has nothing to do with this progress to avian. To prevent further avian, we did closed reduction and internal fixation, and only anterior capsulotomy was done to fix the TFL muscle pedicle bone graft with a screw to prevent graft dislodgement. We conclude that this method of treatment neglected displaced femoral neck fracture in the young adults using closed reduction internal fixation with 6.5 cc screw and tensor fasciitis muscle pedicle fixed with a screw is a simple, effective, economic, and reproducible method. The sample size very small in our study. The similar study on larger group is required to reach a definitive conclusion.
So can you tell me one thing that while putting the tensor fascial lata graft on the subcapital region of the neck, did you chisel out the neck there or directly you put the screw? You know?
सर चीज़ल नहीं किया था बस मतलब वहाँ ऑस्ट्रोटम से एक और केवाई से एक वहाँ बना के और उसके बाद उसमें अटैच
केवाई से तुमने ड्रिल किया था वहाँ
नहीं गाइड वायर सर
While putting the graft,
हाँ
be it posteriorly, quadratus femoris or whatever you
टेंसर
have to
fasciitis लाटा
you have to make it slot, put it into that slot and push it a bit into the head. That is the ideal way of doing it. Did you do that?
not really well sir
You didn't get my point.
I don't
After fixation and opening up
yes sir
the neck either from the posterior or from the interior side,
anterior
what one has to do is to make a slot
हाँ
for the graft.
yes slot हाँ
Graft has to be of proper size.
हाँ हाँ
For posterior Mayer's operation, which we here
Anterior,
in
but
call
yeah.
Bax's operation,
Uh-huh.
5 into 2.5 size of graft is to be taken. And the whole graft is to be put into a slot over the neck.
yes sir
And part of it has to be pushed into the head. Did you do that?
sir yes sir, I
You
don't.
didn't make a slot.
Yes.
You just put it over
Yes.
this and tied it.
But put a screw
Or it's screw. No, but you have to get it in, because it is a cortical cell all around. You have to have the cancellous surfaces of graft and the neck to be interposed to each other. And that's why you make a slot.
So you put your cancellous graft here. You put a cancellous graft over the cortical bone.
yes sir
Do you think it will unite?
it's a
Until unless you
No,
make
no.
a slot.
You please elaborate your operation technique. That is regards a confusion between us. Please elaborate how will you fix the graft. That's
first we using of K-wire and osteotome we make a slot just subcapital region of neck of
so
female.
approach is
Anterior Smith-Peterson
Smith
approach.
person. Oh, you opened it.
Opened it and
Capsule.
Capsule open inverse T shape. Then at the subcapital region making a slot and then attach and fix. Only.
So you have made a slot. Where? In which area?
Subcapital region and anteriorly.
So you have to make a slot. That is why sir asked. You
That's
cannot
what
put the
we are
graft on an intact bone, na? So you have to make a slot. Otherwise, you cannot put the graft inside. Because what is the length of your graft?
2.2 into 2 centimeter.
Yes, 2 centimeter. 2 centimeter graft cannot be placed on the over the directly on the surface. That is why sir was asking. So you have to make a slot. Okay. So that is the. Okay. Thank you.
Sorry, sir.
I'll call upon the next speaker, Dr. Vinay. Dr. Vinay, is he here? Okay. Next is Dr. Ashutosh. Dr. Ashutosh Kumar. Is he here? No, he is also not here. Dr. Upadhyay Shubham Shankar.
Am I audible? Yes, sir. The greatest glory in living lies not in never falling, but in rising every single time we fall, or every single time our femoral head collapses. Good morning, stalwarts of orthopedics. I'm Dr. Shubham Upadhyay from MGM Medical College, Kishanganj, and today I'll be presenting on the outcomes of tensor fascia lata muscle pedicle bone grafting in treating avascular necrosis of femoral head in adults. So without any further ado, let's dive into the topic. Avascular necrosis or AVN occurs when blood flow to the femoral head is disrupted, causing bone tissue to die. Common causes include trauma, prolonged steroid use, and alcohol abuse, though it can also be idiopathic. If untreated, AVN leads to collapse of femoral head, resulting in severe pain and limited mobility, eventually making joint replacement necessary. Early intervention is the key. Now we have a lot of treatment options for AVN, from conservative methods like traction and bisphosphonates to operative intervention like core decompression, rotational osteotomy, muscle pedicle bone grafting, and of course, total hip arthroplasty. Core decompression can provide short-term pain relief, but unfortunately, it doesn't stop the disease progression or revascularize the femoral head. Osteotomy is another option, but it's technically challenging, reduces the already compromised blood flow to the femoral head, and makes future total hip replacement much more difficult when eventually needed. But see, the thing to note is that all these procedures are really aimed at one thing, and that is to prevent or delay total hip arthroplasty for as long as possible. Now, you might be wondering, why shouldn't we just go straight to arthroplasty? Let me explain this to you with a simple example. Imagine you're driving on a road and you get a puncture in your tire. What do? Do you replace the entire tire or do you patch it up? And that is exactly the difference between TFL grafting and total hip arthroplasty. THA is a full-fledged joint in replacement and is highly invasive, which makes it ideal for older patients with advanced AVN, where femoral head has already collapsed and cannot be saved. However, this procedure significantly alters joint biomechanics, and implants come with a limited lifespan of almost 10 to 20 years. On the other hand, TFL graft is a less invasive option, particularly suited for younger patients with early stage AVN, where we can still preserve the femoral head. The graft helps to delay the need for THA, and importantly, it maintains the natural biomechanics of the joint. So in essence, THA is like replacing the tire, while TFL graft is more like patching the leak. It allows us to keep the original joint intact for as long as possible. Our study aimed to answer a critical question. Can we preserve the femoral head in early stage AVN and delay the need for more invasive procedures like total hip arthroplasty? To do this, we measure clinical outcomes using Harris Hip Score, which evaluates pain, function, and range of motion, and radiographs to check for revascularization and joint stability. The study included 25 patients with 32 hips with early stage AVN who underwent TFL grafting and were followed up using Harris Hip Score with radiographs. We included patients aged 18 to 50 with stage 2 and 3 AVN, excluding those with stage 4 AVN, implants, or any kind of active infections. The surgical procedure begins with an anterolateral approach, exposing the femoral head and neck while preserving the posterior blood supply. We perform curettage of necrotic bone with core decompression and then harvest the tensor fascia lata muscle pedicle along with a section of iliac bone. The muscle pedicle is very critical because that is what brings blood supply to the femoral head, while the bone, it adds structural support. The graft is then put into the slot and fixed with cannulated screws, allowing the femoral head to heal and function. For post-op protocol, we begin mobilizing the patient within 24 hours, encouraging them to sit up early to maintain blood flow. Range of motion exercises start at 2 weeks, partial weight bearing at 4 weeks, and full weight bearing by 8 weeks as the graft stabilizes. We conducted follow-up at 6 weeks, 3 months, 6 months, and 1 year to assess both radiological and clinical outcomes. Radiographically, we saw that in most cases, the necrotic bone revascularized and the joint space was preserved, as we can see in these images. We used Harris Hip Score to measure pain, mobility, and overall joint function, showing a clear picture of patient recovery and graft success. Our results were very promising. 37.5% of the patient had excellent outcomes with Harris score between 90 to 100. Another 46.8% had good outcomes showing substantial improvement in mobility and reduction. Only 6.2% of the patient fell into poor outcome category, suggesting that TFL graft effectively preserves joint function and delays the need for total hip arthroplasty in most patients. To conclude, tensor fascial lata muscle pedicle graft is a highly effective hip preserving surgery for patients with early stage AVN. It significantly delays the need for more invasive procedures like THA and is particularly beneficial for younger patients in reducing pain and improving mobility. And before I open the house for questions, the last thing that I would like to say is, the best thing on your neck is your own head. Thank you very much for listening. If you have any questions, feel free to ask.
Good.
Excuse me, one of the slides you have said that while you are comparing with THA with muscle pedicle bone graft, you have said that in THA the recovery is delayed and restricted. Can you go through quickly the slides which you have said?
Sure, sir.
It is completely wrong.
So just a second, I'm going back to the slide.
फिर से लगा दो स्लाइड्स भाई, स्क्रॉल करो,
Scroll करो, that is
आगे
wrong.
जाइए. नहीं ये वाला नहीं,
ये वाला नहीं।
ये नहीं, अभी जो प्रेजेंटेशन खत्म हुई है.
उपाध्याय।
हाँ ये वाली डॉक्टर
हाँ।
उपाध्याय
स्क्रीन पे नहीं आ रहा है.
आ गया. बस लाओ बड़ा करो.
हाँ, go
आगे
forward.
चलो, आगे चलो.
आगे चलो, आगे चलो.
नेक्स्ट नेक्स्ट नेक्स्ट, बस
Yes,
रुक
yes,
जाओ.
yes. Here recovery is longer and more restricted, and in tensor fascial lata is quicker and early mobilization.
I advise my patients to start weight bearing from the very next day.
एक्चुअली ये रिवर्स हो गया है सर, ये वाला इधर होना चाहिए था, वो उधर. So it is quicker and early mobilization for a total hip, and it is longer and more restricted for a tensor fascial lata because you cannot ask immediately to weight bear. Or biomechanics alters, if you do a joint replacement properly, it maintains the biomechanics of the hip. That is done for a successful total hip replacement. But anyways, any other comments, sir? So early stage, what do you mean by early stage of AVN?
Stage means Figatalis stage 1, 2, 3. We were including only stage 2 and 3, where the femoral head has not collapsed yet, and it could still be
One of the
preserved.
cases you have shown the femoral head was already collapsed. How do you suggest that doing a muscle pedicle will help in regaining the shape of the head?
So the
One of the cases you have shown in your another in which you have shown some MRI also. Next. You see here,
Yes, sir.
which side you have done?
Sir, it is a
Already the hip is collapsed. The right side you see, it's flattened, deformed. So how long was your follow-up for these cases?
So we usually follow up for 1 year at least, and some cases have even been followed up for 2 years.
So I think the follow-up time is too less. Okay, it requires a longer follow-up time. Mic दे दीजिए Dr. Paul को.
Thank you. Actually, I am also doing this procedure for a long time, have a publication also. So basically, there are some adjacent procedures should be added. Whether you have added or not, that is the question. Even in presence of collapse, then Ficadalate stage 3 up to 2 millimeter, 2 to 3 millimeter collapse, not more than that. That can be taken over with this technique by during this cord decompression. Once you impact the TFL graft in a specific direction, that will maintain that collapsed area. Sometimes it is rectified, sometimes it's not rectified, but still it maintains that position as it is a vascular graft. So basically there is a specific strategical impaction in anterosupralateral aspect during the insertion of the graft. That is the technique. Do you use that?
So, no, I haven't mentioned that thing in my presentation, but that is being done.
Have you used or not?
Yes, sir.
Yes, that is the
Yes,
main
sir.
technique, which is how this is a corticocancellous graft, is a very strong graft.
Yes, sir.
So once you make a slot in that direction, and if you put a impaction on that,
Yes,
that is a very good technique for this one. Another thing, you can delay the THR. We have already published in JBJS. It is a 15 years study. It's a that is a long study, which have shown that if it done in a young active patient, sometimes at 45 years, is a lifelong procedure. No THR was needed in that. So that is excellent proposition which is done in younger patients.
Yes,
so I am happy that you have adopted a physiological treatment option in young orthopedic. Thank you.
I think it is a good study, but what Dr. Paul has rightly said, if it is a collapse, you have to do a compact bone grafting. If you don't do that, only muscle pedicle won't help. It will definitely collapse. So there are different techniques. Even if you don't do a muscle pedicle, there are techniques in which you just impact the graft and then you leave it, and that has also shown some good results.
Prefibula graft.
Okay, fine. Thank you. I'll call upon next Dr. Shreyesh Shetty. Is he here? No. Dr. Harpreet Chhabra? No. Dr. Biprajit Roy?
Yeah, Dr. Paul, what do you prefer in muscle pedicle bone grafting? Is the same from the tensor fascia lata or something else?
Yes, that is a very good question. So for the neck femur fracture, where there is a maximum, there is comminution, there is a posterior cortical comminution. So it is seen there are the almost 70-80% cases in grade 4, the Garden type 4 intercapsular neck femur fracture, there is a natural comminution on the posterior part. So we have to give some, we have to select some muscle pedicle bone graft from the posterior aspect. So that is the most important. So in the posterior aspect, there is a quadratus femoris is a large, is almost 3 centimeter by 3 centimeter graft can be taken from the posterior aspect of the base of the greater trochanter. So that can be placed. At least 1/3. That is for the neck femur. And for the avian is in the anterosupralateral aspect. So we have to choose the muscle pedicle which from the anterior side, that is the TFL. And another role, as Dr. Shandeep rightly mentioned, that we have to take care of this minimal collapse, that is up to 2 to 3 millimeter collapse. That can be taken by special impaction during the insertion of the graft.
Do you prefer the Sartorius muscle pedicle?
Yes, previously I used, but now it is not used.
It has got a very low blood supply.
Yeah.
Dr. Maggu sir, what do you prefer, sir? For the preservation of the head of the femur, osteotomy or muscle pedicle bone grafting?
Muscle pedicle bone graft has no role in a collapse situation. So better you bring a healthy bone. It is my experience and what literature says. You bring healthy bone under the weight bearing dome. That is the concept. And you debride the dead bone and put grafts there so that there is a chance of revascularization. But a healthy bone, so I prefer an osteotomy.
Thank you, sir.
Okay. In collapse situation is okay.
Dr. Biprajit Roy.
Good morning, respected teachers and inmate delegates and stalwarts of orthopedics. My name is Dr. Biprajit Roy, a second-year postgraduate trainee in the Department of Orthopedics from MJ Medical College and LSK Hospital, Kishanganj. Now, start the day with a great humor that many of our patients with tennis elbow comes with that, I am having tennis elbow, but I didn't play a single ball of tennis in my whole life. So my presentation will be on the treatment of lateral epicondylitis with platelet-rich plasma or corticosteroid injection, a short-term comparative study. Now, as per F. Runge in 1873, who was a famous said in German literature that it's a chronic symptomatic degradation involving the wrist extensor tendons on their attachment at the lateral epicondyle of the humerus. Again, Sir Nish has come who studied the histopathology and said that it's not even an inflammatory condition, but a tendinosis, which is a failure of the normal tendon repair mechanism associated with angiofibroblastic degeneration. Now, the mechanism, most of us know that it's due to repetitive motions that cause strain overloading to the origins of the extensor tendons, the lateral epicondyle, there's the ECRB, which is the most common tendon to be affected, along with the anteromedial surface of the extensor digitorum minimi and the deep surface of the extensor carpi radialis longus. Now, in both these three tendons, we can see there is an internal microtear in the tendon. Now, treatment has mainly two options, either a non-operative or operative. The non-operative we prefer the most. Historically, the injection choice of lateral epicondylitis has been corticosteroid injection, which provides pain relief and improves function and strength due to the anti-inflammatory properties. But as we know, it's not even an inflammatory condition. Now the question comes whether the treatment by corticosteroid injection is optimal and ultimately beneficial. That's my main study. Now, coming to the biological agents usually stimulate the body's natural healing process on the involved tissue, whereas the platelets vehicles as a delivery balance pool of healing factors like the PDGF and VEGF and the TGF-beta. Now, platelet-rich plasma, which is also a plasma fraction of autologous blood, having a platelet concentration above baseline, is mostly used in this study. Now, coming to the aims and objectives, to compare the effectiveness of single-dose injection of autologous platelet-rich plasma with corticosteroid injection in treatment of lateral epicondylitis and to measure the outcomes in a short-term follow-up study. Coming to the materials and methods, this is a prospective study of about 40 patients, which includes 26 females and 14 males who were diagnosed as suffering from lateral epicondylitis for the period from July 2024 to September at MJ Medical College, Kishanganj. Now, the drugs used are of two types, 3 to 4 ml of autologous platelet-rich plasma and triamcinolone acetonide of 40 mg per ml, which is admixed to 2 ml of lignocaine. Now, the inclusion criteria, duration of pain over lateral epicondyle more than 3 months. That's basically those patients who have failed of conservative treatment. Lateral elbow pain, that is maximum at the lateral epicondyle, and the pain is aggravated with pressure on the lateral epicondyle on resisted wrist dorsiflexion, that's Cosen's test. Exclusion criteria, chronic inflammatory diseases like rheumatoid arthritis after segregating from the by doing the polyarthritic profile, fibromyalgia, uncontrolled diabetes and systemic hypertension, on anticoagulation therapy, ulcers over the elbow, and steroid injection within last 3 months. Outcome measures, all the patients were followed up to 4, 8 and 12th week of post-injection using visual analog scale score and the disabilities of the arm, shoulder and hand outcome score. Now, coming to the injection protocol, those patients who met the inclusion criteria were randomly allocated into 2 groups by a lot method. Fresh blood was drawn from the PRP group patients, about 27 ml, and anticoagulant is added. Then blood was centrifuged at 15,000 rpm for approximately 15 months, and 3 to 4 ml of plasma was prepared. Outpatient basis, same was for the corticosteroid technique. Now, coming to the results, here is the graph showing the visual analog and DAS score. In steroid group, there is a decrease in the initial phase of VAS and DAS score, and later it shows a plateau, where the platelet-rich plasma group, it significantly decreases, but there is no plateau. Similarly, the results were both compared in steroid and plasma group, showing post 8 weeks plateau of the steroid and the plasma group, who shows a significant dip. Now, coming to the conclusion, a single injection of autologous platelet-rich plasma improves elbow pain and functional activities more actively than corticosteroid injection in lateral epicondylitis. These improvements were maintained over in our follow-up period without any significant complications, whereas corticosteroid groups gives better result up to 8th week, that's initially, and after that pain decreases slightly in comparison to PRP. These are my references. Thank you, sir.
Okay, Dr. Biprajit, did you use any rehab, physio, or any other supportive thing, or only the injection and that's it?
Sir, I have not done any rehab. So, these patients were taken 3 months before who have failed of the conservative treatment. Then I have gone for the invasive procedures.
Okay, so already they had taken 3 months of rehab, and the failures you have taken for the injection.
Yes,
and after that you have just given the injection and nothing.
Follow up for next 3 months.
Okay, so it was only your clinical diagnosis, or you got the ultrasound or something else also done for these?
Sir, first we have done, sir, actually these people are from poor economic strata. Some people have gone for the ultrasound or MRI, but maximum of the patients were on clinical basis only.
So it was your clinical diagnosis,
yes, sir,
which led you to that. And you found that the results of PRP is better. Only one injection you gave.
Yes, sir.
So what is usual recommended? Is it 1 injection, 2? What is nowadays? What are the studies?
So nowadays it says that 3 injections can be given at an interval of 2, 3 and 6 months of interval on PRP. But on steroid, if you give one injection, it can be delayed for 4 to 6 months, as it causes angiofibroplasia of the tendon sheath.
Did you use, which scale did you use to assess the function?
Yes, sir.
Which scale?
So visual analog scale and dash score, sir.
Dash and visual.
Yes, sir.
Any other question from the house? Okay, thank you.
Thank
The
you,
next
sir.
speaker is Dr. Nihal. Is he here? Chalo, aa jao bhai.
Good morning, respected faculties and colleagues. Myself, Dr. Nihal, will be presenting on functional outcome of fracture neck of femur managed with femoral neck system. So coming to the introduction first, 50% of the fracture around the hip involve femur neck. The incidence is more common in females as compared to males. The risk factors are female sex, increasing age, low estrogen, poor health, and tobacco and alcohol abuse. In young patients, the DHS and the CC screw system is the most commonly implant used for osteosynthesis, whereas the femoral neck system is a relatively newer implant. So why FNS? The cannulated screw system has its own problem. It is a weaker construct, it collapses and the head goes into varus. The problem with DHS is that it collapses with lateral protrusion of implant, and while inserting it, there is an insertional torque which causes the spinning of the head. Coming to the implant, the femoral neck system is a fixed angle gliding fixation device, allows controlled collapse, consists of plate with locking screws, bolt and anti-rotation screw. The bolt acts as a central load carrier, has a blunt tip to reduce the risk of cutout, and the bolt glides in freely of the base plate. The anti-rotation screw also has a blunt tip, lock with the bolt at a fixed angle, glides in the barrel along with the bolt, and along with the bolt, the anti-rotation screw is responsible for rotational stability. The base plate has 1 or 2 holes, has a small implant footprint, therefore responsible for the minimal invasive surgery. It provides angular stability, and there is 20 mm of collapse which we can have in this implant with 15 mm within the barrel, thus reducing the risk of lateral protrusion of the implant. The method: first take the patient on fracture table, reduce the head, put a center guide wire, put an anti-rotation guide wire, then use a triple rimmer to rim, insert the bolt in the base plate, hammer it, lock the plate with the screw, and then put the anti-rotation screw. So my study design has a sample size of 26 patients, were evaluated based on Harris hip score and lower extremity functional score. The follow-up period was 24 months, and the classification used for the fracture was Gardens. So coming to the result, the mean Harris hip score was 88.2, which corresponds to good. The mean lower extremity functional score was 66 out of 80, corresponding to approx 83%. Out of 26 patients, 60 patient has excellent hip scores, 13 good, 7 in fair, and 1 patient has avian, which went into poor. This is the Harris hip score according to the classification, Gardens classification. So results: total 26 patients, mean age of the patients were 48, union time, average union time was 16 weeks, mean Harris hip score 88.2, mean lower extremity functional score was 83, and 1 patient underwent revision surgery due to avian. So these are my cases. First case, 1 year follow-up. Second case, fixed with FNS, 4 weeks post the X-ray, and 1 year he can squat and sit cross-leg. The third, high Powell angle, fixed with FNS, went into avian, done THR was done after 2 years. So discussion based on a study done at Ayor Institute in Davos, biomechanical performance of FNS was equal to DHS and significantly better than 3 cannulated screw system in terms of resistance to leg and neck shortening under cyclic loading. FNS was proven to be twice as strong as multiple screw system for femoral neck and leg shortening. Comparison with DHS, the FNS uses a smaller incision, thus less bleeding, and the anti-rotation screw in the FNS is inserted through the base plate, avoids need for additional soft tissue dissection proximal to the plate. It Contrary, DHS has a better availability, good clinical result, cheaper, biomechanically more stable and familiar implant with the surgeons. So my take-home message is internal fixation with anatomical reduction is considered state of the art for younger patient. FNS allows compression and controlled collapse, low complication rate, reduced risk of lateral implant protrusion and lateral hip pain. Biomechanical performance of FNS is equal to DHS, but there is no spinning of head as seen in DHS, and FNS is twice as strong as multiple screw against femoral neck and leg shortening. Thank you.
Any questions from the house?
So in which way do you prefer that FNS is better in terms of the operation is mandatory, you have to do, but the one about the implant choice,
Yes, sir.
what is the biggest advantage, like control collapse you have said, you know?
Yes, sir.
So how much control collapse you expect in a FNS?
Sir,
after the proper reduction is also mandatory.
Yes, sir. So 20 mm, there's chance 20 mm collapse of the implant, but it depends on the quality of the bone. If the bone is strong, the collapse won't be that much. But it is seen that in an osteoporotic bone, it collapses a lot.
In osteoporotic bone?
Yes, sir.
So in DHS the collapse will be more, or in FNS will be more?
Sir, according to that study, it's both comparable in that osteoporotic bone, the DHS and FNS.
I don't think so. I don't think so.
I think FNS, that is the beauty of FNS, it won't allow much collapse leading to coxabrevia, which is the drawback of DHS.
Yes.
Isn't it?
Yes, sir.
Drawback, if there is the absorption at the fracture site, to approximate the bone ends, it will collapse to come into contact, while FNS doesn't allow it.
Yes, sir.
So, I think there your observation was quite contrary to what
अगर
happens.
कम्युनिशन है बहुत ज़्यादा तो क्या करोगे?
It doesn't give 20 mm collapse. You know.
20 mm is
Too much. It's too much. It's 2 centimeter.
Yes, sir.
Do you think that it is needed, or you want 20 millimeter?
No, sir. The maximum there can be. Yes.
Suppose your reduction is proper, then you don't want much collapse. You know.
Yes, sir.
That is the disadvantage in DHS. And what about the drill?
Yes, sir.
The bone loss inside the head and that is much more in DHS, but in FNS it is very less.
Yes.
There are two things happening. One thing, there is a frank absorption at the fracture site. It has to collapse to get into union. And the second is, bone is not that much strong, and by the time union takes place, if it is kept as such, the length is maintained, ultimately union will happen. And I would like to have that thing to happen, to avoid coxabrevia, and that is the beauty of FNS over DHS.
Yeah, so, sir, I think FNS allow only acute collapse, means compression, not gradual collapse, yeah.
It gets locked, otherwise तो होता ही रहेगा collapse. So that is the advantage over DHS. Otherwise DHS with the 1 CCS is also working well, है ना? So that is also working well. I think ठीक है, we end this PG session paper. I would like to give few comments here to all the PGs, those who have presented and those who have not presented. Actually this session is done so that you can learn how to present it, your paper, your work, which is very important for your future. So 3-4 things I would like to tell. Most of the speakers did not make their PPT well. The PPT was full of your thesis lines, which you have just copied from there and put it. So one slide you should not put more than 6 to 7 lines, and not more than 6 to 8 words in a line. So that is very, you don't have to write and keep reading from it. So it has to be points, and then you can elaborate it while presenting. So ये एक important चीज़ है. दूसरा, the fonts. Somebody has used a small font for a heading, and then the body is bigger. And many a times you have changed the font in between. एक जगह font आपने एक slide में कुछ use किया है, दूसरी slide में दूसरा use किया हुआ है. So you are presenting a paper for a competitive session. You have to be very serious for presenting these things. Okay. So दूसरा ये हो गया. तीसरा, where to highlight. what words you need to highlight, the color combination, that is also very important. Okay? Chautha is the timing. Whenever you present, always learn to present. Practice before presenting on stage, whether you are finishing on time, because it has the mark system for your timing also. This will be for all sessions, PG, free papers, competitive sessions. Okay? So ये 4-5 चीजें आपको याद रखनी है.
And,
ठीक है?
all, and
Few
also,
things I would like to add more. One is important to have a contrast, like a color combination is very important. If you are going to put the yellow over the green, you will not be able to see it very properly. So color contrast is very important. Never ever cross the time. Bullets for the special points. For every point you want to highlight it, there must be a bullet or a star in front of the starting the words. And remember it, less is more. For the adult education, if you are putting the less on the slides, you can explain the things in a much better way. So that is, these are the points which has to be taken care of. Yeah. Thank you very much.
thank you, sir. Thank you, sir. So, after our PGs, now we are moving to the next session, which is specifically designed for the postgraduates. So, better to stay in the halls. I request all of our postgraduates, and that will be on the HIP examination, okay, which will be taken care of by Professor A.K. Paul, sir. Everybody must be aware of him. There is no need of introduction to sir. So, now we require your few minutes for a great moment, especially for the Indian Association of Trauma Surgeons, change of guard ceremony. Just we'll take a few minutes only for that, because it's a prestigious moment for all of us. So I would like to request to come on the stage, Sudhir sir, Sudhir Kumar sir, the current president of Indian Association of Trauma Surgeons. And I request Ranjit Kumar Singh sir. Hey, sir, please, please. I request all of our respected seniors to come on the stage. अरे इतने लोग आएंगे भी नहीं. It's a heart-touching moment for all of us, especially for the president, who had spent the whole time with all experiences. Now I request Sudhir sir
Now after
to hand over the necklace.
good morning. After yesterday's successful program, and now today we are conducting PG. In between, we will have change of guard. Now for the last 1 year, my dear younger brother has been looking after and nurtured the organization very well for 1 year. Now it is time to hand over the charges, the change of guard, I would say. So, our next president is Dr. Sudhir Kumar Singh. So, So this is time to hand over the charges. May I request Dr. Sudhir Kumar to...
Thank you, sir. I think all of us should give a clapping.
Thank you, Professor Ranjit sir and Professor Sudhir sir. They have given me the responsibility of IATS. Being a president-elect, I will definitely work for this, and I will definitely coordinate with Dr. Sandeep to organize the next conference at Delhi. Thank you. And I have forgotten Dr. Mangu sir. I am thankful to him, sir, and Dr. Paul. Thank you, sir. You have come and attended part and parcel of this conference. So, my personal request, please come. I am thankful to Dr. Bhuvan sir, Dr. Rajiv Anand, who has helped me in achieving this post. Thank you.
A great congratulations, Dr. Sudhir Kumar Singh sir. First of all, I extend my heartfelt thanks to Dr. Sudhir Kumar, who helped me much right from Siliguri to Patna. Sir, hope in the future you also help me always. Yesterday, I left announcement of one thing, very important thing. IATS announces traveling fellowship of 3 weeks to JBCH Kolkata for sports medicine under the leadership of Dr. Rajiv Raman. So all the PGs are requested who passed out can join this fellowship scheme. There will be certain criteria which will be announced on the website. And at last, I salute the captaincy of Dr. Rajiv Anand, who has huge capacity to organize such an event. Today morning, I asked my registration counter, what will be the count of registration? It will be 251. Give a big clap to Dr. Rajiv Anand. Registration has crossed 250. It is a big thing for IATS. And I thank you again, the organizing team, for wholehearted support. Thank you very much. Over to Dr. Rajiv Anand.
Thank you very much for these kind words, Dr. Bhuvan Singh, sir, Secretary General of IATS. And my heartiest congratulations to Dr. Sudhir Kumar Singh for becoming the new president of IATS. And I hope the past president, now I can say Dr. Sudhir Kumar has a dynamic personality that I have seen it throughout since 10 or 15 years. And he has always supported us in everything. Now he has become a big pillar for AO as well. So he'll be helping all the PG students and post-PG for the AO things also. And I hope he will shower his blessings in IATS in the future endeavor also. And in the same time, it is much expected from Dr. Sudhir Kumar Singh to take this baton ahead for a longer height for the IATS. And this time I have organized this conference in a very short duration of time, but I devoted my wholehearted capacity and workouts to make this happen, a successful conference. And next time, Dr. Sandeep is taking over as an organizing secretary in Delhi, and I have no doubt to say that he is a brilliant fellow, and he will do this conference in a bigger way. So I hope that. Yeah. Thank you very much.
First of all, let me congratulate Dr. Sudhir Kumar for taking over charge as president of IATS. The outgoing president, the brilliant surgeon and academician, Dr. Sudhir Kumar. He has worked a lot to bring us to this level. And अभी ऊंचाइयां तो और भी हैं जो हमें achieve करनी है. This organization started with the intent of educating young budding surgeons of this part of India, that is Bihar, Jharkhand, Odisha, and of course Bengal. So, and that in our mind, we have decided to have a core committee of academic-oriented surgeons. And among them, the first name which comes into mind is none other than Dr. Maghu sir, Dr. Paul, who has dedicated whole of his life in teaching and teaching only. And of course, Dr. Sudhir Kumar, he has been a great AO fellow. So we will have a group of people who will guide us how to improve the things for this target audience or of budding surgeons. So I propose a permanent group of Dr. Maghu sir, Dr. A.K. Paul, Dr. Sudhir Kumar, of course, my dear friend Dr. Rajiv Anand, a dynamic person, and now my younger brother Sandeep. So, is it right? And Ravi Chauhan, oh, he will be looking after the new project, which is our dream project for this year. So, with all these words, again I congratulate Dr. Sudhir Kumar to look after all these things. Thank you, sir.
One thing is, I do always say life is in our profession, is a lifelong learning process. So be there every time, not barely the delegates are going to learn, being as a faculty, even we are going to learn a lot from each other. It's a mutual exchange of the knowledge. So there is always a possibility of doing the things in a better or in the things in a different way. There is nothing called as right or wrong.
Few words from Dr. Rajiv Anand again and Dr. Anil sir.
Congratulations, Dr. Sudhir Kumar Singh, and all the best.
Kanaya sir is telling congratulations. Dr. Paul, please, and Dr. N.K. Maghu sir.
So I am feeling proud to be an extended family of Bengal and Bihar. So just one word, just I am saying that very persons, the young orthopedic surgeons, and I'm very proud of this a part of the team. And I think this one of each one of this person that will teach at 1,000 people in future. It is my belief. And it's a big thanks to this the organizing team. And please, big applause, please. So this is the essence. And the Bihar means, what is the meaning of the Bihar? Jo harta nahi hai, jo koi hat na sochna nahi hai. So I am very proud of the part of this family. Thank you.
It's very fine, beautiful organization, doing very well, and it is still in its infancy, I should say. So let us include more recent advances, some lectures, some work going in the laboratory. That will be a source of attraction, and it will make a difference with other conferences. So these two things are, I think, very important for future action.
Thank you, Dr. Sudhir, for having this opportunity to serve the everything. I hope you will do the justice, and I am very clear this organization will help the new but coming orthopedic surgeon and the society. Thank you very much. Thanks.
Hello. First of all, I should thank my younger brother Sudhir, Dr. Sudhir. He is very competent, and even he's not from Sudhir to Sudhir. Interesting. And Bhuvan has already made history by doing this event, and for the long live this IITS. Thank you.
If anybody is interested, one can visit our center for the purpose of the training and learning few bit about the orthopedic care, how you can go ahead with the complex kind of surgical procedures, reconstructive procedures. My field of interest is hand surgery and the hand surgery and the spine surgery. Anyway, we are doing a significant number of trauma. So anybody who is interested can visit our center, and one can contact Dr. Bhuvan Singh regarding these things. How long they want to get a fellowship on behalf of the Iatscon.
Thank you very much, sir. I will discuss to Professor Sudhir Kumar detailed, and then I will announce that very fellow also from IATS to Dr. Sudhir Kumar's hospital, Jagannath Hospital, Ranchi. So I will discuss to sir, and then I will announce how much IATS can give him. One fellowship is already announced from IATS. IATS will give 25,000 rupees to the young budding surgeon who have passed PGs or resident, and he should stay at 3 weeks at Calcutta in JBCH hospital. And second announcement is from Dr. Sudhir Kumar to Jagannath Hospital, Ranchi for hand surgery and spine surgery. I will detailedly discuss to him and then announce how much IATS can give that very fellow. Thank you.
Nitty-gritty of how the arrangements will be made will be discussed with Professor Sudhir, and then we will publish it on our website. Thank you.
Many congratulations to Dr. Sudhir Kumar sir, Patna, for getting charge of the president of IATS, and and we must hope that under his leadership the IATS will grow further, and definitely many the fellowship will come under his guidance, and we will achieve newer heights in academics. Thank you, sir.
Sandeep.
So first, congratulations to Sudhir sir. And now the reins in your hand, and in coordination with Delhi, we would like to do a mega show. And this time there were 250 registrations. I welcome all of you sitting in the hall as well as on the dais. You all are welcome to Delhi, and we will try to the best for IATS. And thank you Rajiv sir, Bhuvan sir, Anil sir, Praveen sir, and the whole of the organizing team, because I know how difficult it was to organize this in a short time. I have seen Dr. Rajiv sir working day and night for last 15 days. Even at night, 1 o'clock, if I am messaging him, he is ready to answer that. So hats off to you, Rajiv sir, for a wonderful show. And congratulations to all of you. And we would like this association to grow day by day in a better way. I am happy that I was associated with this from the day one when the first conference occurred in Siliguri. I was also there. So thank you very much for the team to making me a part of this team. Thank you, sir.
Thank you, sir. It's really a privilege to be here and to be associated with IATS from now onwards. I am really felt privileged and honored for this, and especially in association with Paul sir and Maggu sir and with the seniors. And definitely congratulations to Sudhir sir. And I really want to say to the all youngsters that it's very rare that somebody is taking care of your interests. Basically, that is more important in these days, that some organization is going to promote you for your fellowships, for your academics. That's a great thing that IATS is doing. Congratulations to everyone. Thank you, sir.
Congratulations, Sudhir. We are proud of you. You are the member of Baisali Orthopedic Club, and we feel proud. Thank you.
सुपर हैं सर, थैंक यू वेरी मच।
So I think we should move on. I request A.K. Paul sir to please take the podium for the HAPE examination.
Hello, good morning. Good morning to all of you. So I think, please come closer, please. All the PGs, please come closer. Please come closer so that we can give interaction. So this is not a session that we want to judge you. So it is a very, very friendly session where we want to clear your doubt. Is it okay? Okay, please. Okay, can you give one mic to one side, another mic to other side? Please come closer. हाँ वही बात है. So it is better. Is there any provision to bring all the chairs? Some chairs on the 4 chairs this side, 4 chairs on that side. 4 chairs on this side and 4 chairs on that side, so that we will interact better. 4 chairs on that side, 4 students and 4 students on that side. 4 students that side, 4 students on that side. 4 each. So interaction will be better. We can interchange in between. Yes, please. Please घुमा दीजिए, ऐसा करके घुमा दीजिए. हाँ, yes. थोड़ा पीछे कर लीजिए, so space will be there. Space, create a space. Sir is there, please. So keep 4 that side, keep 4 that's on that side. Sir is there, the sir will interact. Keep 4 only for that sir. Yes. Please bring that. Okay, very good. Okay, so we'll start. So I think all of you know the method of examination, orthopedic examination, isn't it? First, what is the first step of, suppose we are going to examine a hip. What will be the first step of hip examination? Examination only. Do you want to discuss on the history? History? Is it record or not? History? Okay, just we go very short. Do you have a pointer? Slide changer? Slide changer, pointer? Excuse me, slide changer or pointer? Slide will be changed also? Slide will be changed or not? Okay. Side will not change. Side changer, yes. Okay, very good. Yes. Okay. नहीं हुआ? इधर में लगा दीजिए, इधर में लगा दीजिए डायरेक्टली. Okay, so this approach of the orthopedic patient is, this is in a nutshell, what is the purpose of taking the history? There is basically the purpose, and there is some protocol and some structure. Do you, okay?
So this protocol is we have to take the chief complaints first, followed by the history of present illness. There are 3 points in the history of present illness. They were first you have to elaborate the chief complaint. Okay. Next is the important positive history in favor of your diagnosis, important negative history to rule out the diagnosis, and last is the vital function. Basically, purpose is to, what is the purpose of the history? It is the categorization of the disease. It is the categorization of the disease. Okay. So, if any there is the chairs are there. If anybody wants, please come here. There is chairs are there. So, purpose is the categorization. That means the broad. First of all, we have to categorize the disease. That may be a traumatic, it may be infective or inflammatory, neoplastic, like this. So, I can ask any single question from each side, which is the salient feature of a specific category of the disease. Okay. So, you are going to become the specialist, and you had like a legal action, like a legal lawyer, medical lawyer. So, you have to take the specific answer. Okay. So, first of all, from I come to this side, there are all the 2 chairs already vacant. What is the salient feature of a traumatic disease? Suppose it is a neck femur fracture of a, or it is a supracondylar fracture of humerus. So, first question is, what are the points in your favor? Okay, what are the points in favor of your diagnosis? So, we have to prove that it is a traumatic disease. So, what are the points in favor of a traumatic disease? Be specific, please tell. Give one mic on this side, one mic on this side. Yes. Anybody, whatever come in mind, tell.
I feel one is crepitus and one is fractures and mobility is there and pain.
See, this is I have first once I have asked your, so I have to start this sequence should be followed. Sir, from the history it is this, from the examination it is this. Okay, okay.
Pain is
so
the first component.
so this try to do that. So what is the from the history? Even over the telephone you can diagnose that it is a traumatic disease.
Pain is the history of fall.
Are you agreed?
History of fall.
No, he is not agreed. History of fall or trauma. So, okay, is the statement is correct? Your history of fall and trauma. Is the statement is correct? Yes or no? Yes or no? Yes? From audience? Yes or no? Yes? I am not agreed. Because patient is telling, I have a history of fall 5 years back. Now I am complaining of pain in that set. Is it a complete statement? So what is a complete statement?
History of fall, history of acute fall following.
So I am
pain.
telling in a nutshell. So history of patient complain of painful swelling and incapacity to raise up, get up, rise up immediately after trauma. That trauma may be a significant trauma, that may be a trivial trauma. Okay? So that is the complete answer. Do you understand? So you are going to become the expert. So behave like expert. So that is the purpose of the history. Next on, come to that side. What is the salient history of infective disease? Is it required or we will skip the history and go to the examination? Yes or no? No. Discuss? Okay. Salient point, salient, even over telephone you can diagnose this is an infective disease. Tell the specific point.
Chronic history, long standing. Fever and raised temperature.
You?
Redness, swelling.
Redness, swelling. So see, the fever if you tell,
and
you are partially correct.
History of discharge of sinus is there.
Absolutely right. Absolutely right. So if it is a discharge, see the fever may be a feature of a low-grade fever, even it can happen in rheumatoid arthritis also, okay? Or any chronic debilitating illness that cannot stamp as a infective disease. And whatever else is a pain, swelling, that is a common thing. But if it is a discharge, so discharge is basically it is a feature of inflammation, that's a infection, okay? So next one, what are the salient history of a inflammatory disease?
Stiffness,
yes.
Morning stiffness.
Pardon?
Morning stiffness.
Total 5 is there.
So try to complete
Dolor,
your
rubor,
sentence.
dolor,
Try to complete your sentence, yes.
Dolor, rubor, calor, and total 5 is there that reach out. Dolor,
See,
one is rubor is there. Increased temperature, increased redness, increased swelling, and loss of function.
In loss of function. Are you right? Is the question, answer is right? These are the features of inflammation, no doubt. So, I have asked what are the features of a inflammatory disease? What are the inflammatory disease? What are the inflammatory diseases or in orthopedic? So, inflammatory disease world is divided, which is exclusively for the male and exclusively for the female commonly. Which inflammatory disease is reserved for male world?
Ankylosing spondylitis.
And exclusively reserved for the, not exclusively, commonly reserved for the female?
Rheumatoid and all other.
Absolutely. So, now tell what are the points in favor of this diagnosis. Suppose that we came across it is a rheumatoid arthritis, we came across ankylosing spondylitis. So, the first question asks what are the points in favor of
early
it?
morning stiffness. Early morning stiffness.
Is it a clear statement, complete statement?
More than 1 hour. Early
Yes.
morning stiffness.
See, so this is your answer. So, it is only one. Anyone? Any other points in favor?
Small, now I have.
Small joint involvement.
Small joint involvement. Is it complete? See, you have to complete. So, I'm for the sake of time, I'm telling there are 4
Early
features.
morning stiffness, which resolves with movement.
Yes. Body stiffness at least more than 45 minutes to 1 hour resolves with movement. That is one. You are right. Then there are polyarthralgia or polyarthritis. There are difference of arthralgia and arthritis. Polyarthritis. What do you mean by the poly? That is also a question. But it is there. It is in favor of inflammatory arthritis. Polyarthralgia, polyarthritis. Second. Next is first is the morning stiffness. We told polyarthralgia or polyarthritis. Next one, chronic course. It cannot be the acute one. And fourth one is waxing and waning of symptoms. Symptoms comes, goes away, again symptoms comes, goes away for long duration. So, these are the 4 features. Why you have asked? So, any case you have come across the rheumatoid arthritis or ankylosing spondylitis, you have to tell like that. Now, there are some predilection of affection of specific joints in rheumatoid arthritis and ankylosing spondylitis. I am not going into detail. Okay. Now, come again. What are the points in favor of degenerative disease? History, salient history of a degenerative disease. Sir, if there is a difference of opinion, please share. I am also not complete. I am also learned from you. So, please give another mic to sir. So, if there is any comment, please sir, please. I am also learning. I am also learning from you, sir.
We all are learners.
Yeah, please, sir. Please. Okay. Points in favor of degenerative disease.
Progressive loss of progressive decline in function.
What are the specific, may name a specific degenerative disease? Pardon? Specific degenerative disease. I am asking very basic question. Spondylitis. Okay. You do know the term of what is the term indicates? It is a degenerative disease of the spine. Very good. So, which term is basic? Spondylosis or spondylitis? I am very sorry to ask this question because sometimes it is asked, this sort of question is asked. Spondylosis. Why not spondylitis? So, then same question, who has come in the earth first, hen or egg? Same question, which one is the initial part, spondylosis or spondylitis? Same question, which one is the first one? I am telling that osteoarthrosis and osteoarthritis. Which one is the first one? Arthrosis. Use a mic, so everybody will hear. Listen. Arthrosis is first. So, I have asked a simple question, name a orthopedic disease, orthopedic degenerative disease. So, now tell loudly.
Spondylosis.
That is one, and another.
Osteoarthritis.
Osteoarthrosis. Why not? Why it has come? You have asked. I am not complete. I don't know everything. I also learning. Why it is called? It has come first. Why not arthritis has come first? Do you know that osteoarthrosis is a disease of which structure?
Joint.
Which component of the joint?
Cartilage.
Cartilage. Which cartilage? Hyaline.
Hyaline.
It does not have any blood supply, nerve supply, lymphatic supply. So how the inflammation sets in? For the inflammation, you have to come with blood vessels, inflammatory markers, everything. It doesn't have a blood supply. So that is why it's first is the degeneration that invites infection. You understand? Is it clear? So osteoarthrosis. What is the diagnostic feature from history of the arthritis? All of you know the degenerative arthritis may be primary, secondary. Now secondary is almost obsolete. Primary is almost obsolete. Almost all are secondary. So what are the diagnostic feature? Even over telephone, you can tell that you are going to have osteoarthrosis.
Chronic pain with progressively restriction of movement.
Suppose I am being specific, osteoarthrosis of a knee joint. So symptoms, typical symptoms.
Pain in knee joint and restriction of movement.
Pain in knee joint can happen in rheumatoid arthritis also, even in a trauma. Specific. Do you know that?
Yeah, medial side joint pain, medial joint line tenderness will be there.
Tenderness is examination.
Yeah, and
history.
before that,
that's the even over telephone you can diagnose.
there will be no variation of the diurnal variation. All time pain is there.
That is the pain following inactivity. See, it is given in the textbook. Reference is the Taples textbook. Pain following initially. Once the inflammation sets in, it is osteoarthritis, and there will be pain, tenderness, everything. Okay. Initial phase you doesn't have find any tenderness, only the symptoms. Now come to so that is the purpose of history. What are the points, salient feature of a nerve injury, neurological disease? Nerve injury. Suppose it is a ulnar nerve injury or radial nerve injury. So these set of questions you have to come across. First question, what are the points in favor of a diagnosis? You have to start from history followed by examination. History. Trauma can lead to traumatic disease, that can lead to inflammatory disease, everything. Salient points in favor of a neurological disease.
Tingling sensation in the
tingling sensation. So students say, what happens if you sit for long period keeping your elbow for long time on the desk, you have a tingling numbness. So does it have a neurological disease? So think of all, you are going to become specialist. We have to give a salient features like a advocate. Even you have to write it. Depending on your writing, you have to be assessed in your society.
sensory and motor loss.
Absolutely. So nerve components has sensory, motor and autonomic. Autonomic we don't have any much more. So yes, there are some features. If there is autonomic, we have to take care of. But commonly, we have a sensory, motor. So how do know it is a motor neuropathy?
Power.
See, that is the problem. You have to change your thinking process. So even over the telephone, if they tell something, you can understand what is going on. Can you tell that, sir, I have loss of power? Doctor साहब हमारा power चला गया. ये कोई बता सकते क्या? Think of rationally. Pardon? Yes.
Weakness, sir.
Weakness, yes, say they can tell have a weakness for long time. This is not a specific for neurological. Motor neuropathy. Suppose there is, I am telling very specific, suppose a radial neuropathy following some trauma had happened 3 months back, patient has some problem. It's a
loss of function.
Loss of function, patient is telling I'm doing some combing here, everything. So this is a loss of function. Is it specific for a radial nerve injury? Think in this manner. So can you tell that, sir, हमारा wrist drop हो गया है? See? Now, pardon?
Difficulty in weight bearing or weight lifting.
Difficulty in weight bearing. So patient has a very कामचोर है, say हमारा लेता नहीं है, लेता नहीं है. This is it a feature of nerve injury?
No.
I am telling. Very simple answer. Patient will tell there is a loss of active movement, but passively he can do that. डॉक्टर साहब हमारा तो रिस्ट उठा नहीं सकता, लेकिन अगला हाथ से हम उठा सकते. So that what does it mean? loss of active motion, but passively you can do that. So that is the feature. See, very simple. So that is a motor neuropathy. Okay. Now sensory neuropathy, similarly, I have just for the sake of time, I am going. So think in this manner. You know everything. You are going to become the specialist, but your writing, your thinking is like a footprint of the society. You are going to become judged on your thinking process, depending on your thinking process. So don't be correct, be rectify yourself. So sensory, again there are there is a no sensation, there is a anesthesia, or there is a less sensation, that means hyposthesia. There may be much more sensation, this is hyperasthesia. There may be perverted sensation, that means paresthesia, perverted, P for P, perverted paresthesia. So अब तो चिंचिन कर रहा है, कोई झिंझिन कर रहा है. So tingling numbness, what are those? These are tingling, there is an abnormal sensation. Or without touching, patient can tell severe pain. Without touching, that means allodynia. Okay, like phantom limb sensation. Limb is not there. Okay, so these are the problem by which we can easily understand this is a neurological disease. Okay, so that is the purpose of that. Purpose of the history. If you take the proper history, if you आधा काम तो खत्म हो गया. समझा कि नहीं? Now another disease remaining, it is a metabolic disease. What are the metabolic disease we come across in orthopedics? Metabolic disease?
Osteoporosis.
That depends on the age. In different age group, there are some metabolic disease. Metabolic disease in the immature age group?
Rickets.
That means we are concerning about the two metabolic diseases we have come across in orthopedics. One is the calcium, vitamin D,
and calcium.
Another is
phosphate, vitamin C.
Vitamin C is not very important for the orthopedics. One is calcium metabolism. Another is
vitamin D.
Vitamin D.
Among the three components of the body, carbohydrate, fat and protein, among the three one is a property of orthopedic surgeon. Metabolism of one, carbohydrate, fat, protein.
Purine metabolism.
From that, which metabolism we concerned orthopedic surgeon, apart from the calcium, deficiency of one enzyme.
Allopurinol.
Pardon?
So,
which metabolism? Purine metabolism. I don't know. I am very ignorant for that. I'm very simple person. I have not read it. I'm very concerned.
Gout, sir.
Gout is the which metabolism defect? Protein metabolism defect. So be simple. Don't try to make your life complicated. There is a two metabolism, calcium and protein. So come to the calcium. So it is depending on the immature group, immature age group, which disease it is a? Ricket. Adult?
Osteomalacia.
Malacia. Older?
Osteoporosis.
Very good. So come these three. So one of the one. What is the feature of ricket?
So splaying, cupping.
So there is a progressive deformity. Generalized deformity. Progressive generalized deformity of a developmental age. Okay. There is a classical ricket. There are some other types of ricket. So that is one. Come to the adult. What is the problem? Even over telephone you can diagnose.
Sir, bowing of legs, pot belly.
So do you expect in osteomalacia there will be bowing?
Not osteomalacia, rickets.
Pardon?
Rickets.
Rickets ho gaya. And adults, come to the adults.
Pain in shin.
Pardon?
Shin pain.
So this is the calcium metabolism defect. So we have to know what are the functions of the calcium. So there will be abnormality of that function. There are four functions of the calcium. First is the consolidation of bone. Heart, okay, but for the orthopedic relatively concern is coagulation of blood.
Coagulation.
Okay, So calcium metabolism defect occurs, there are 4. So first one is the consolidation of the bone, so bone becomes weak, there is a back pain all over the body. If it is a young adult male or female, who one is affected in osteomalacia?
Female.
Female. Why?
Because postmenopausal.
No. As an adult, osteomalacia. Young adult male or female? You told is a young adult male, female is much more prone to osteomalacia. Yes, you are right.
Yes, sir.
Because they are not going to sunlight. Yes, very good. So there is the basics. So there is a generalized body ache all over the body. That is one. Muscles are weak. So axial muscles will become weak all over the body. The muscle contractility is less. So there is a GI problem. GI problem. The nerve conduction will be. So there is generalized weakness. The muscle is irritable. Okay. So these are the features of osteomalacia. Now come to the osteoporosis. Osteoporosis is reduction of the height 3 centimeter or more if it is after menopause. Okay, again back pain all over the abdomen, and most of it is a fragile fracture. So these are the way we have to, so these are purpose. So history of present illness basically is the elaboration of the chip complaints, positive negative history, and vital functions. Vital functions is 5 vital functions. This is appetite, loss of weight, bladder, bowel, sleep. If these vital functions are affected, that means it's a grave disease. Some other disease we left, like the malignant disease. Malignant disease means there's a benign or benign disease is usually present with the swelling. Malignant disease usually it is a small, there's a number of history period is less, and these vital functions are affected. If it's a spreading infection or is a malignant disease, vital functions are. So that is why it is more important. You have to write it down in your paper, these vital functions. Past history, you have to make this a specific disease or treatment before. So what is the, how to differentiate? There must be some, there is an interval, there is a symptoms-free interval between this onset. Okay, symptoms-free interval. Now personal history, ABCD, A for allergy, B for bleeding, C for contact, D for the drugs, E for environment, F for family history. Okay, and the female for menstrual history, and child for the immunization history. So ABCDF, menstrual history, okay. Now 7S questions. If you ask this, you can easily categorize the disease. So they are already discussed about the different types of disease. Sex, age, starting, whether it is acute or gradual. Site or site is a single site, multiple site. Okay. Symptoms, local symptoms, span, duration. Duration is a short duration, a long duration. Everything we discussed. Spread, progress, and severity. This is that is a systemic or cardinal symptoms. Okay. Now, elaboration of the chip complaints are to pain. So, for depending on the pain, how to differentiate, categorize whether it is a mechanical pain, inflammatory pain, or the infective or neoplastic pain. Only 2 questions. If you to ask these 2 questions, you can easily diagnose. Even over the telephone, you can diagnose. What is the aggravating factor and what is the relieving factor? For the mechanical cause, suppose there is a malunited fracture neck femur, or there is a fracture neck femur followed by avascular necrosis with some structural defect, collapse has happened. We discussed in the morning. Collapse has happened. So structural defect. Okay. So if it progresses, then leads to degenerative arthritis. So in stage 1, stage 2, so there is a painful radiological changes without collapse. Stage 3, collapse. Stage 4, with degenerative arthritis. Okay. So suppose in the stage 3, so it's a mechanical disease. So how do we differentiate this mechanical disease from the degenerative disease or inflammatory disease? Yes. Degenerative leads to inflammation. Stage 4 leads to all features of inflammation. So how to differentiate this stage AVN stage 3 and 4? Mechanical, there is only 2 factors. That is a pain, whether it is aggravated by the activity, relieved by rest. Okay. Inflammatory, pain always at the rest, relieved by activity. Suppose there is inflammatory disease, rheumatoid arthritis, ankylosing spondylitis, they remains better when they are in activity. When they takes rest, severe pain. Ankylosing spondylitis at the late part of the night, you woke up. Even during the change of the bed, patient is very severe pain. In the morning stiffness, you already told that 45 minutes to 1 hour morning stiffness. There is a difference between morning pain and stiffness. They are both different. And also there are 2 points, another is night pain and night cry. They are different. Night cry is different. Do you know that night cry and night pain? Anybody? How do it differs? Night pain means this is a rest pain. Whether the patient takes rest, whether in night or day, patient will complain of pain. But for the night cry, you have some sleep, and patient woke up from the sleep, and that indicates specific disease, that is arthritis, there's a lack of articular cartilage, and during this conscious time, the muscle spasm that kept the bones apart, once the patient is deep sleep, that muscle spasm goes over and this articular surface ups. A night cry is a specific feature of arthritis, and which is the commonest cause of arthritis in India, it is a tuberculosis. So that is the night cry. So that is how you can argue. And then the second cause of night cry, commonest cause. First is the tubercular arthritis. That is how we differentiate tubercular synovitis from tubercular arthritis or a healed arthritis. Suppose the patient has treated by tuberculosis 5 years back. Now it is healed, but patient is complaining of pain somehow. How do you know whether it is a arthritis or not? It is the reactivation of the arthritis. From the history, that is the night cry. And for the examination, how do you differentiate between the healed arthritis and active arthritis? Active, suppose hip arthritis, tubercular arthritis. That is a tenderness. Tenderness is a feature of inflammation. This is a single test, simple. Okay, so inflammatory. And now the neoplastic infective, pain is, activity is the aggravating factor, but there is no relieving factor because the cause is always present. Okay. Now symptoms of progression, some diseases are progressive, some diseases are not progressive. Some is a traumatic disease, some is a malunited fracture, trochanter. It is a non-progressive disease. Name a progressive disease. Name a progressive disease. Osteoarthrosis, yes, osteoarthrosis. Or suppose avascular necrosis, it is a progressive disease. Tuberculosis, it is a progressive disease. So how do you know it is a progressive disease? 3 points in your history. There is a deterioration of the symptoms, gradual restriction of the activities of the daily living, and gradual restriction of the walking distance. These 3. Okay? And the rest pain is already discussed. How to differentiate between rest pain from the night cry. So how to categorize the disease? Simple 2 questions, aggravating factor and the relieving factor. Now the general survey, I am not going into detail. Now examination protocol. So examination protocol is basically this is now coming a big way. Before examination, we have to protocol should be followed. So first is you have to take the consent of the patient. Next you have to position. You have to make the patient comfortable. We cannot tell lay down everywhere, sit down everywhere. You have to take position and the sequence to be followed. Okay. Now say all of you know these are the examination protocol. There are 7 broad heading and each broad heading is subdivided into 3 broad heading, 3 subheading. Okay. Suppose inspection is divided into attitude deformity, swelling or wasting and skin abnormality like that. Okay. So for the lower limb, first examine the gait. Okay. So gait is basically, so I will show the gait. For the orthopedics, there are basically 3 gaits we have to going to become master. Basically 2 gait, one is a stable gait and there is an unstable gait. So what is the abnormal, any abnormal gait is known as the limping. So if the limping is associated with some instability, that is known as lurching. Okay, that is known as lurching. So for basically it is a 2, stable gait, unstable gait. Okay. For stable gait, for the orthopedic point of view, there are 2. One is painful gait, that is antalgic gait, and that is short limb gait. Okay. Okay. And at the unstable gait, they basically commonly one unstable gait we discuss. We are very much common. What is that? Trendelenburg gait. Another unstable gait. Gluteus maximus gait. Okay. Which 3 muscles is required for this gait? 3 muscles. Basic 3 muscles we require during our gait. Remember this. What are these 3 muscles? So first of all, because before that, First I have to do some basic questions. What is the anatomical position? Can anybody tell? Because every examination should be based on this anatomical position. What is anatomical position and what is the plantigrade position of the foot? These two questions sometimes it is asked. What is anatomical position? Okay. So this is the standing straight, looking. The look of the gaze is parallel to the floor. Hands will look forward. Limbs are parallel as possible and side by the side. So this is the anatomical position. Now plantigrade foot. Foot should be plantigrade. This is also a component of the anatomical position. So what is plantigrade foot? Because this is required for any case where the foot problem like the CTEV, like calcaneus valgus foot, any foot position we require to make a plantigrade foot. So what we have to know? What is plantigrade foot? Anybody? Anybody from the audience? No, don't know? Plantigrade foot? We stand is like a tripod. Tripod is required. Where is that photographer? Photographer has a tripod. Photographer, the lady photographer, he has a beautiful tripod. So tripod, see this is the tripod. Tripod is the most available. The guide of attachment, all are tripod. We are standing. We are standing like this, one-legged stance. This is the exercise you can do everybody. Everybody have this exercise because this stability is important. Stability is important. So whether you are able to stand like this. If you are able to stand, your tendency to fall on the ground will be reduced. Tendency of the fall is a very, very bad thing. Even your very, very strong body, if you are fall on ground, they have some fracture. So this is a specific test. And the nature has given this power with the tripod attachment. There are several tripod attached in your body. Okay. So foot has a tripod attachment. What are those 3 points? One is heel, and that is, pardon? Second metatarsal. Second and fifth metatarsal. Calcaneum is one, I have already told. Second, is it agreed? Second metatarsal? Metatarsal, fifth metatarsal. Which part of the fifth metatarsal? Head, base, head. Do you think second metatarsal, is it okay? Why nature has given 2 sesamoid on the base of first metatarsal? Why the first metatarsal phalangeal joint is the most important joint involved in gout? All answers are there. The same answer. So first is the base. Yes. Tripod is first is the calcaneum. Second one is the head or neck of the fifth metatarsal, and third one is first metatarsal base. First metatarsal base. So plantigrade foot is patient can bear weight on these 3 points. Okay. So this is the plantigrade foot. So for the gait, we require 3 muscles. One is the gluteus maximus, another is the quadriceps femoris, and lastly is gluteus medius. Even the patient has a Trendelenburg gait, patient can walk. But among the 3, in another third muscle is absent, so patient will not be able to walk. That is third one is, you have to identify, it is your property. That is the iliopsoas. If the iliopsoas of the hip, so choose one muscle from the hip, choose one muscle from the knee, choose one muscle from the ankle. So one muscle from the hip is ho gaya, gluteus maximus. For this only this muscle you are standing on on bipedal gait. The subhumans cannot stand in a bipedal. But for this, so remember this muscle, we have to give homage to that muscle. And for the knee, it is a quadriceps. And for the ankle, tibialis anterior is the most common muscles involved in polio. Still the patient will be able to walk. Tibialis anterior involvement is a dynamic, supination in CTEV, in tibia gastrosoleus. tell gastrosoleus. Gastrosoleus. These three muscle is required for at least power MRC power 3. If it is there, whatever the muscles in the lower limb, if it is paralyzed patient will be able to walk. Okay. So this is most important, and this is the basic things we have to know. Gait, basically these two components, stance phase and the swing phase. Stance phase is 60%, this is more, swing phase is overall, this is overall 40%. Okay. After there are 5 steps in the stance phase. There is a heel strike, this is a foot flat, mid stance, heel off, toe off. Okay. And for the swing phase, this is the early swing, mid swing, deceleration. Okay. So this is these 5 components of swing stance phase, 60% and 40% is the now hip examination. Okay. So basically it is a stable or short limb. If it is a limb length discrepancy more than 2 cm, you will be able to detect. Okay. And unstable lurching or Tenenbaum gait. Tenenbaum is a common. There are some other unstable gait. So prerequisites of gait. Prerequisites, you have to adequately undress the patients. Otherwise, you cannot be able. You are not able to examine. You walk with ABCD. Okay. Walk barefooted, straight, at least 20 steps. That is 3 meters at usual space. If the patient is asked to walk rapidly or slowly, you cannot make it out. Okay. So, okay. So, any abnormality from bipedal unassisted gait is the limping. Okay, it is walking. Okay. So, gait examination is basically for the orthopedic, we have to concern about the observational gait analysis. We have to observe from the front, side, back. Okay. So, we have to tell the patient is walking with bipedal unassisted gait. Okay. We have to examine the shoulder, trunk and the lower limb. Okay, ABCD, it's like as you can see here. Basically, this we need not remember all these things. Now examine this. Now before that, I am play acting. I am play acting for you. We have to identify which gait it is. Okay? I am play acting. Remember, watch me properly. And we have to identify what is the problem. So, answer is within my lecture. So, we have to identify the commonest gait we have discussed in the orthopedics. There is no antalgic gait. See, it's antalgic gait. What are the components of the antalgic gait? Tell that. Stance phase is yes, relatively becomes shorter, and if you watched my face, there are some painful facial expression. But it is a very stable gait. Okay. Now come to that. Now come to. Again, just before going, the antalgic gait, which side of hip limb, which side of the body is affected? Suspect. Which part, which right side, left side? If it is the right side, is the lower limb, upper limb. If it is the lower limb, the ankle, knee, hip. Think in this manner. I was the short stance phase on which side? Right side. So on the right side is the lower limb. Then hip or ankle or knee? Most probably hip. Maybe I have given the calcaneum. Somebody noticed that calcaneum. So there is a possibility of pain in your forefoot also. That is why we are trying to avoid that. So these are the thinking process we have to keep it in your mind. So that is why the gait is the first examination point to be think of in hip examination. Okay, now come to this. This is the first pattern I will show. I will tell. First pattern. First pattern. Okay. Now this is the second pattern. You have to identify the gate. First pattern is 10 number. Why? What are the points in favor of your 10 number gate? Points in favor of 10 number gate? Opposite side means which side? Which side is affected? 10 number gate, which side is affected? He is telling left side. That means I am okay this. That means the left side. Left side. Left side. He is telling left side. Who are please raise your hand and make a exercise on this because we are going tired of. So don't raise both the hands. This side or this side. He is telling it's the left side. Left side, those who are the leftist, please raise your hand. Leftist. Leftist is 1, 2, 3, 4, 5, 6. Rightist. Rightist. 1, 2, 3. 1, 2, 3. 1, 2, 3. So this is which side? So this is what is the problem? Which structure is at fault? What is the function of the abductor? Abduction. Okay. If the abductor fails, how will you manage? So this is also abduction. Okay. So if the muscle fails, then that function, that is a trick movement, is to bring the trunk that side. So once that limb is out of my ground, there is a tendency to fall like this because abductor is not working. So abductor muscles is attached over to here. We contract from the side, this one. If we contract from below, it will look this. Otherwise, it is assisted by trunk movement. It is given in your this Trendelbach original article, not only the gluteus medius but also other muscles that will help. There is quadratus lumbar, paraspinal muscles, which laterally flex the trunk. Okay. So if my other side is so in that position, which gluteus medius, which side of the gluteus medius is being tested? Right side. If the right side fails, then what will happen? So how can it be compensated? That as I am doing. So which side is affected? Which side of gluteus maximus is affected? Now who has on leftist or rightist? Who on? अरे loud पे बोलो भाई. Right side. So leftist defeated. Sorry. So this is the way we have to understand. Okay. That is the same thing. That same thing should be calculated, should be thought of during the Trendelbach test. Okay. So and the next one was shortening. So how to differentiate between the Trendelbach gait to shortening, the short limb gait?
बॉडी स्विंग नहीं करेगा सर.
Can you give a T please? T. चा भेज दीजिए please. Okay. So we have to clinically you have to tell that sir, this is the points in favor of Trendelbach gait. This is why it is a short limb gait. So both are looking similar. The same side limping. One in what this. The Trendelbach gait, body is swinging in a coronal plane, like this, like the older wall clock.
Pendulum.
पेंडुलम देखा है? पेंडुलम कैसे डोलता है? ऐसा करके डोलता है ना? Older clock. But what happened in the short limb gait? So my limb is short. So if we keep it like this, my shoulder will be at a lower level. So during walking, so it is up and down, not at the coronal plane. So that is why it is not a Trendelenburg gait. Okay. So in this way you have to understand. Okay. Now check this. You have to tell which gate it is. Now tell from this side.
Short limb gait.
Yes, please. Okay, you are right. Tell confidently. Short limb gait. Pardon, sir? Why it is short limb? Yes, please tell.
The relaxed spine dips down.
Yes, absolutely.
And this relaxed spine dips down.
Okay. Okay, sir. We'll finish.
No, sir.
Okay.
The relaxed spine dips down when he's walking. Yeah.
Sir, please use the mic, sir. Mic.
Use. Yeah, okay. It's fine.
पानी भी देना है पानी yes please. Okay, you are right. Confident? Very good. Tell confidently. Now watch this. Yes. Okay. One. Okay, which side? That side? Please.
Sir, Trendelenburg gait.
Very good. So now tell, so we have to think of what is the commonest cause of short limb gait in this age group. What is the commonest cause of Trendelenburg gait in this age group? What is the commonest cause of Trendelenburg gait in this? Suppose this is a 9-year-old girl. 9-year-old girl presented with Trendelenburg gait.
Septic arthritis.
Are you agreed?
DDH.
Yes, DDH. From the other, what is the commonest orthopedic disease? No, you have to, आपका body चला गया, फिर आएगा. Pardon? Think common thing first. Okay. Or okay, second maybe DDH, maybe some. Don't tell septic arthritis. It may be a sequelae of septic arthritis. That means the destruction of the. So always complete your. You may be right, but think of in this manner. Okay, now examine this.
Equinus.
What is that? With purpose, with some specific purpose, it is kept. Sorry. Sometimes you may not have classical gait, classical typical gait, like Trendelenburg gait, short limb gait, antalgic gait. In that case, what to do? Then you have to describe. Sir, patient is walking in a bipedal unassisted gait with some features, and there are some possibilities. That is the importance of your examination. We can tell exact fact to the examiner, and then you have to tell the exact what are the thinking behind it. So patient is walking with some, see the shoulder, what is happening to the shoulder? So everything is important. Shoulder is up and down, going up and down, isn't it? And it is not properly adequately exposed. That is the point. So if it adequately exposed, then you have to check the knee what is the position of the knee during walking. But the ankle it is a constantly equinus. There is a up and down, patient is walking with bipedal unsteady gait with drooping of the shoulder, with up and down movement of the shoulder, but you cannot comment on the pelvis as sir is rightly mentioned, and also the hip knee position, but the ankle is remain constantly in equinus position. So, most probably it is a short limb gait with some compensation by the equinus. Okay. Sir, anything to be commented on this? Okay. So, basically the component abnormality to check, I am not going to detail. Antalgic gait, everything I think it is already discussed. Now, see there is another combination. This is another combination. What are the combination? Can you, how do you describe the gait? How do you describe the gait? Try to tell. Patient is walking with a bipedal unassisted gait with some Trendelenburg component and also shortening, isn't it? Trendelenburg component with some shortening and equinus. Sometimes Trendelenburg gait is associated with some shortening. If the shortening is 5 centimeter or more, so there is a, especially in the supratrochanteric shortening, so that there is inadequacy of the abductor lever arm, and that can lead to Trendelenburg gait. Sir, please.
I think it is a combination of short limb and antalgic gait.
Yes, that may be, yes. Antalgic gait also.
Not Trendelenburg, because it is a short step gait.
Okay, okay.
He takes the weight quickly off the foot.
Okay, okay.
So maybe it is a combined short limb plus antalgic gait.
Maybe antalgic is also associated, but the trunk is swaying. See the trunk.
Your trunk will dip always, both the in antalgic as well as in Trendelenburg gait. The shoulder will definitely dip.
Yes.
On the same side.
But if somebody tells that, do you make a fail in the examination?
See,
that is a swaying of the gait on the left side.
Yeah. Left side, he walks with foot equinus and takes off the weight very quickly. For the next step.
Basically, it's a predominantly a short limb gait. What I have told is it is a 5 centimeter shortening, and is more contributed on the supratrochanteric region. There is inadequacy of the abductor lever arm that leads to this sort of compensated tricks movement. So maybe sir is absolutely right. So that is a because of the prevent falling on the unsupported pelvis, they are doing that. Okay, so we have to describe it.
Next time you also include their X-rays.
Absolutely, sir. Absolutely. Thank you, sir. Thank you. Now check this. Yes, sir, please. This is a 4-year-old boy presented with this sort of limping for last 2 years. Okay. And there are some specific history narrated by his mother when she was in an infant. Now the patient is walking like that. He is walking like that, isn't it? Check this. There is swaying of the body, not only the right side, there is a, yes, right side, is how the patient stands. Check this. Patient stands like this, but also on the back side. I kept these radiographs. So, yes, limb is also externally rotated. Absolutely, absolutely.
He dips back as if there is something wrong with the extensor mechanism of the hip.
Absolutely, 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 sir. So take this point, what sir has highlighted. That is why I have told there are 3 muscles. We have to keep it in mind, which is responsible, which is required for adequate walking. So, and among this, one problem is there. Now, can anybody tell which deficiency it is?
Gluteus maximus.
Absolutely right. And see the radiograph. I have to check. I think I have a radio. That is basically, it is a sequelae of septic arthritis. Okay. Okay. Now that is not there. It is septic arthritis. Now for the short limb gait workout. This is short limb gait. So workout is, we have to ask to sit on a stool and to bend forward. Okay. Like this. So which component is shortened? So these are the tests you can easily. So these are the workout for short limb gait. Okay. Not going into detail. Now say check this gait. Check this gait. Which gait? In-toe gait. So what are the possibilities?
Increase femoral angle.
Increase?
Femoral shaft angle.
I can't get you.
Femoral shaft angle.
Femoral?
Neck femoral and shaft angle.
Femoral neck shaft. Anteversion. So yes, it is an increased anteversion, that is one. Next, any other three cause should be keep in your mind and you have to check accordingly. Yes, internal torsion of the tibia. And anything else? Yes, very good. See, so these are the three differential diagnoses. Now come to this. Oh, sorry. And this patient, the video is there, I think. Patient is walking like this. This is walking like this.
Charlie Chaplin gait.
That person. I will check whether the video is there or not. So what is the problem? What is the common? Pardon?
Decreased anteversion.
Not decreased. Think of commonest cause. So now this patient is, I'm giving the clue. The patient is a 12 years old boy. 12 years old boy. See, this is the plumpy area, plumpy patient. This is not
Sleep capital femoral epiphysis. SCFE.
Absolutely right. Absolutely right.
SCFE. Subcapital, sleep capital femoral epiphysis.
What is the classical deformity in slip epiphysis capitis femora? Classical deformity. So that is why the gait is because of the deformity. So it is a slip, so there is external rotation. It is adduction and it is extension.
Okay. Thank you, sir. So this is the case. You can see how the patient sits. How the patient sits like this. How the patient sits. Now you have to have the clue. Okay. Now the internal rotation is more than the external rotation. Okay. We already discussed the differential diagnosis. Already you told. And how do we measure it?
Craig test.
Yes, Craig test. But Craig test is much more subjective. I want the expert comment from sir. I'm not very fond of Craig test, which is a very subjective one. You cannot make it. There is a significant intra-observer and extra-observer variability of the Craig test. Instead of that, the measuring of the internal rotation more than external rotation, and this plumb line test is much more, I think it is reproducible to all. I think. What is the comment, sir? Absolutely right. So this is my experience, same experience of this. And see, this is the thigh foot angle test. So this is one axis to the thigh and another axis from the center of the heel to the second toe. Okay. So this is thigh foot, this is the way. Now this is the opposite. You can see the external rotation is more than internal rotation. The SCP, these are the effect. And this, what is this? This is a very, very important, we have to know. This is a miserable malalignment syndrome. Miserable, what is that? Can anybody describe that? Miserable malalignment syndrome. Patient is a external rotation gait. like this. Miserable from anybody from the hall. This is a secondary compensatory mechanism of the body. Okay. So if there is a increased antiversion, it is external. That is a external. That is external rotation is mode. External rotation of the hip. That is reverse of the antiversion. So how the body will compensate is internal torsion of the tibia, and ultimately that will be the external torsion of the ankle. That is the distal part of the tibia. Okay. So that is the external rotation, excessive external rotation of the hip, that is compensated by the internal rotation of the distal part of the femur. So there is a possibility of the kissing patella. Okay. And that is compensated by the distal tibial external torsion. Distal, and that is the miserable malalignment syndrome. And how to make a clue? You have to make again the rotational component of the hip, the external. That is why the rotation is extremely important. We have to check the rotation. So rotation is if there is a pseudoflexion deformity. So how to differentiate whether is this flexion, this true flexion deformity or the pseudoflexion deformity? That is the only thing, is the rotation. We have to check the rotation. Okay. Even if any arthritis, if you check the rotation of the hip, that may be affected. Okay. So because some flexion may be compensated by the spine also, but rotation cannot be compensated. That will be painful. So that is why the rotation is important. And most important, another clue is check that is the way that rotation can be checked in 3 positions. One is in supine position, keeping the hip extended, supine position, keeping in hip 90 degree, and also prone position, where simultaneously rotation can be checked on both the sides. So this is the condition where the rotation is important. Okay. So this is the gait, and how the position of the limb. This is attitude. You can see already it is discussed. Now what is the gait? Already discussed, I think. We'll past. Okay. Now this is which test is being done? Check this. Yes, this is telescopic test, and this is unstable gait. Already told it. What are the workout? So this is the telescopic test should be done. Now these are the causes. Now the Trendelenburg test. See, Trendelenburg test is positive. Okay. Thank you. Is there any questions, sir? Please your comment. Okay. So is there any doubt? I can discuss. Sir is there. Sir will tell you. You don't have. You will not have any opportunity to discuss in because the sir is also teacher of mine. I am also learning from him regularly. Yes, please.
Sir.
Okay.
Sir,
Okay.
please explain flexion and pseudoflexion difference.
Thank you.
Sir, please explain, sir, again, sir, this flexion and pseudoflexion deformity.
Flexion and pseudoflexion deformity, yes. So, if there is a cause of pseudoflexion deformity, patient is flexed like this. Okay. Now, it may be true flexion or it may be pseudoflexion. Pseudoflexion means it is a contraction of the iliopsoas by any irritation of the iliopsoas. Iliopsoas is contracted. This is a very powerful muscle. So how it can be irritated? That means by inflammatory process or infective process, that is the Carey spine. And Carey spine, if the pus tracks along the fascia of the iliopsoas, so usually from D6, 8 onwards. Why not above? because D6, 8 onwards, it connects with the aperture of the diaphragm. Okay? So it can track down. And the iliopsoas muscles takes origin from the lower part of the dorsal region and upper part of the lumbar region. That is a junction between the transverse process and the pedicle and part of the body. It is tracked down, it is attached with the posteromedial aspect of the lesser trochanter. Okay? So, if there is a collection of the inflammatory process which takes the pathway of least resistance, and the fascia of the muscle is one which has a least resistance, it tracks down through this part, it comes down. There are several ways where how the cold abscess will come in different way. So, that cold abscess that will tracks down along this fascia, it can reach up to its insertion, that can cause irritation of the muscles and that cause flexion deformity. But this is not the true problem of the hip. But if it is a true problem of the hip, so first deformity develops is the flexion deformity. Okay? First deformity is the flexion deformity, and that leads to some movement restriction also. So we have to check the other movements. I have already told the rotational component. The rotational movement is also restricted. So this is a cause of hip. But if it is only the iliopsoas, that indicates it is outside. Iliopsoas is coming outside the hip joint. So it is only the hip flexion is affected, but the rotations are not affected. Okay. Okay. Thank you. Okay. Okay. Please. Okay. Thank you.
All of you just remain seated like this. It's okay with that. You keep on sitting here. No need to move from here. I think it was a very short time with A.K. Paul sir, na? You all must be realizing. He can speak at length for days. So it's okay. So now just we need to move to the next presentation by N.K. Magoo sir, all about Powell's osteotomy. He is the master of that, and you all are privileged to listen to him and to see his video presentation. So all over to sir.
ये देखिए रेजिडेंट्स क्या है। इसको चलाना। अच्छा अच्छा वीडियो कुछ टूट ना जाए, ये इतना मोटा जाएगा नहीं क्या? टूट ना जाए बेटे। अच्छा हाँ कहाँ दबाना है? What is this? This video I am playing again. Should I play? Your attention. Your attention. Residents. ये कहाँ गए सारे? चले गए? तो यार आगे आओ ना, ये रेजिडेंट्स को दिखा रहा हूँ मैं. कोई आएगा? नहीं आएगा. नहीं, आई वाज जस्ट आस्किंग ए क्वेश्चन. आगे मूवमेंट्स की जरूरत कोई नहीं, आपको जहाँ अच्छा दिखता वहाँ बैठो. व्हाट इज दिस? ये this is trochanter. This marking is of trochanter. Now what movement you are seeing? See, it is a tight tensor fascial lata which moves anteriorly and posteriorly with the adduction movement. Just I noticed one video, so I thought I should show you. So today we talk of osteotomy around the hip. Bowel osteotomy I talked about 10 minutes yesterday. I will again include. ये तो कोई केस नहीं है. नहीं. ये क्या हो गया? ये हो गया. थोड़ी स्लाइड्स बहुत ज़्यादा हैं, आप मुझे जहाँ कहोगे मैं रुक जाऊँगा. हमारी फ्लाइट भी है डॉक्टर पॉल, और आपके साथ बिग बॉस बैठे हैं भुवन साहब. इनको भी बता दें कि कि हम यहीं नहीं रह जाएं. See, hip is essentially a weight-bearing joint. The article surfaces are congruous. So this marking I have done for you. So this is the congruity of the joint. And यार इसको बंद करो भाई दोस्तों, ये फुर फुर मत करो इधर. ये क्या कर रहे हो आप लोग? कोई डेमोन्स्ट्रेट करना है क्या कुछ? आपके लेक्चर के बाद की तैयारी कर रहे हैं. So this is how the concavity is developed. यार मेरा पास से मोबाइल वहाँ रह गया, बड़ा काम की चीज़ है. तुम्हारे पास है? थैंक यू. हेलो, अभी थोड़ी देर में बात करूँगा, मैं लेक्चर ले रहा हूँ. So this is how it is developed. Thus, any abnormality in the position of the femoral head with respect to a acetabulum during the growth period can produce an abnormal acetabulum as you find here, and this leads to arthritis. So this is incongruity, and our objective is to have congruity towards normalization. So this altered congruity of the acetabulum resulting in maldevelopment is referred to as acetabular dysplasia. If you broadly somebody asks you definition, so this is the incongruity which is referred to as acetabular dysplasia. And this leads to arthritis, I told you. So two types of osteotomies we shall talk about today: pelvic osteotomy and proximal femoral osteotomies. And I told you yesterday three things: muscle balancing, body lever arm and muscular lever arm, congruity of the joint, and top of the trochanter should be at level with center of head of femur. Three things are essentials. So we have to increase the weight bearing area on the head of the femur, give a stable hip, prevent early osteoarthrosis. So two types of osteotomies are there. One is that change the shape and size of the acetabulum. यार ये प्लीज शोर मत करो यार, ये तो अगर आप प्यार करो, there should be no noise. So called as reshaping osteotomy, wherein you change the shape and volume of the socket of the hip. And you may change the direction of the acetabulum. So it is directed laterally, inferiorly, anteriorly. So if you change this orientation, it is called as redirectional osteotomies. Like the periacetabular osteotomy, we change the direction. Now here, you find here, this is verticalization of the acetabulum. So you may tilt it down. So it will be a reshaping type of osteotomy because you are changing the shape of the and volume of the socket of the hip. Now it is a Degas osteotomy. It's a very simple thing. This is the outer cortex. This is the inner cortex of the supraacetabular iliac bone. So when I separate it till the triradiate cartilage, so there is a gap, and I put a graft here to maintain it. So it is a reshaping osteotomy. Pemberda osteotomy and Degas osteotomy are reshaping osteotomy. When you want to contain the head of the femur and shape is not okay, it is verticalization. So we are giving a correct shape to the socket of the hip. If there is a question, please ask me. That is the right time. It's a PG teaching session. And that is how we ask in examination. कि क्या करोगे इसका? So two osteotomies I have named it. So redirectional osteotomy, एक ही बोन, सिंगल इनोमिनेट osteotomy of Salter हम करते हैं. आपको पता है कि 5 years तक करते हैं, 7 years तक. एंटीरियर स्पीक iliac spine के ऊपर हिंज होता है पीछे और इसको नीचे कर देते हैं, डाउनवर्ड एंड फॉरवर्ड. So single innominate osteotomy of Salter is a redirectional osteotomy. So double innominate osteotomy also, triple osteotomy, steel osteotomy आप सब लोग जानते हो, and periosteotomy of Gans आजकल नई osteotomy आई है. इसमें acetabulum उसकी कॉलम को इंटैक्ट रखते हैं और सॉकेट को सारा घुमा देते हैं. So that is other developed periacetabular osteotomy, which is a reorientation osteotomy. You seat this acetabulum over the head of the femur. So here, this is a Salter osteotomy. You bring it down on the head of the femur. Can be done up to 5 to 7 years. So this is a reshaping osteotomy. Again, double innominate osteotomy. One osteotomy is here, above the anterior inferior iliac spine, and this is at the level of isthmus. And this is, you can do the osteotomy at the superior pubic ramus also. So again, that is also a double innominate osteotomy with a Salter's type of osteotomy. Again, you do the reorientation of the socket of the hip. So you can do triple also, superior pubic ramus, inferior pubic ramus, and a Salter's type of osteotomy. So 3 osteotomies in one go. But the problem in this type of osteotomy is that you have to cut the ligament. The ligament is very strong. So this ilioischial ligament, ischiospinous ligament has to cut. Otherwise the acetabulum will create difficulty in rotation. So that is one problem which we face. That is how the periacetabular osteotomy of Gans has become popular. So this is from the posterior aspect, the spinous, ischiospinous ligament, which you have to cut to permit a rotation of the column. So this periacetabular osteotomy, so 3 cuts you have to make. Here, the iliac and the ischial. So this is from the outside. The column is intact. This is the ischial spine. So you are lateral to it. This is the iliac, this is the posterior, this is the ischial. Now acetabulum is free. You can rotate it. So this needs a special osteotome. So periacetabular osteotomy. So here you put a Shan screw, and this is the periacetabular type of cut. 3 cuts are made, and you are using this Shan screw as a lever arm to bring the orientation of the acetabulum on the head of the femur correctly, downward and forward, the way you like. So periacetabular osteotomy, a very special osteotome is used, and the Shan screw is a lever arm. I assisted this osteotomy in UK. So up to 54 years of age, this type of osteotomy can be done. So this is a 16 years girls, where head is subluxated bilaterally, it should be mobile. And I told you, if you don't contain this head of the femur, this is the point where there will be stress concentration of the forces, and this is going to lead to arthritis. So we are going to prevent arthritis. We have to contain this head of the femur into the socket, and we'll do the reorientation type of Gans periosteobular type of osteotomy. It should be reducible, you should know it, should not be fixed, and now this is being covered. So Salter less than 7 years, the cartilage should be open, try radiate, and when the cartilage is closed, you can do triple inominator osteotomy and the Gans osteotomy. So this is CDH, which I did. Now this girl is more than 24 years old. So this is a neglected one. She is 8 or 9 years old. And now you cannot do Salter. So the best osteotomy to contain this hip is the Degas osteotomy, the Pemberton osteotomy. Degas osteotomy I did. I have shown you one drawing. So this head is out. It is dislocated. So you combine it with 2 osteotomies. One is the varus, because the limb is long. The proximal femur is longer than the other side. You cannot put it back. So you make the fossa empty, excise all the fibrous tissue, ligamentum teres, do a varus osteotomy, shorten the femur here, contain it, and then combine it with a pelvic osteotomy, that is the Degas osteotomy. So here is the Degas, and here is the varus. So 2 osteotomies have been combined. So here again, this is varus. So valgus is converted into varus to contain the hip. And here is the Degas, which is fused now. This was the graft. So this was the outer cortex, this is the inner cortex of this supratrilated cartilage acetabulum. See the incision, single incision, both the procedures done. Now she can squat both ways. She can walk full weight bearing. I have done my best to have the recent X-rays. After 22 years, this girl is probably, she is not coming. So I have a follow-up up to 2010. You see here 5 years and maybe even more. Here the implant is removed. See, after the CDH, when it's reduced, the shape is developed. The head and socket, we have achieved congruity. We have achieved full weight bearing. The center, this is slightly higher because it is a congenital problem after all, since birth. And she has no limp at all. It is a stable, pain-free, mobile hip. Now this is a shelf procedure, other type of osteotomy. This is done by Professor Tulli. I am following this case because this patient comes to me frequently in the Rohtak region. This is also a procedure when joint is not congruous and there is verticalization and difficult to reduce or maintain, so you can do a shelf procedure. So this is a shelf taken from the outer cortex of the iliac bone. In between there is a capsule. So this will prevent subluxation of the joint. This is the lateral view, and you see here. So I think I showed you this case yesterday. So it was again a stable mobile joint. I showed you 22 years follow-up of this patient yesterday. So an osteotomy is the transaction of a bone to correct axial and other deformities. You can shorten a limb and you can lengthen a limb. So to correct a deformity, we transact the bone and give him the desired biomechanical position. But at times, we create a deformity. It is not written in the books. Here we have done a deformity. It is a Shane's osteotomy. We cut the bone at the subtrochanteric level and then medialized and abducted the distal fragment. So we have created a deformity so that the weight bearing is done from the side of the pelvis to the proximal femur and then to the distal femur. So weight goes from the side to this angulatory force. So 4 types are there. Can I have some water, please? Thoda pani de dein. Thank you. Lineal osteotomy. Thank you. Torsional osteotomy. You do not find classification as a chapter anywhere in literature. So I have made as a PG teaching lecture. Lineal osteotomy, torsional osteotomy, translation osteotomy, and angular osteotomy. When you want to do lengthening and shortening in one plane, that is a lineal osteotomy. So this is lengthening or shortening. It is a lineal osteotomy. Not difficult to remember. When you do rotational alignments, like here, we have done a rotation, it is called as a torsional osteotomy. I will give you more examples. Now you see patella is looking inward. So it is a torsional deformity. Dr. Ananda told you so many cases. I am showing you the same, moving further ahead as far as the treatment part is concerned. You see? So he is the son of a poet. He has undergone multiple surgeries. He was a case of congenital dislocation of the hip. So I think his last surgery was varus and internal rotation, and he was given hip spica when he was 8 years old. That time it was done by Professor Tulli. 2 surgeries done in Kanpur earlier. So he has a torsional deformity, and you have seen it is very difficult to walk with internal rotation at least. So I did a valgus osteotomy and derotation it. I corrected it. There is shortening here. Black arrow shows there is a shortening also. Besides, this is a foot rule, so shortening and a torsional rotation, internal torsion deformity, seen by patella also and medial malleus also. You have to examine it thoroughly. Examine the whole axis. And here you see, I have done a valgus little bit, and external rotation, patella is nearly normal, nearly rotation. And he is also gained in length. And here, the weight is borne by a very thick capsule, which is working as a shelf, because there is no roof. It was dislocated, undergone 3 surgeries, so there is nothing like true hip, true socket is not there. So we are taking advantage of the musculoskeletal tissue around it, and capsule is very thick. Tennenberg test becomes negative. See neglected cases. So this is what we call it biological fixations. Why should we be mad for this THR unless it is absolutely indicated, unless the age permits, unless the condition is of ankylosis, pain not responding to other procedures. Please stick to biological procedures. I am thankful to you, my friends, that they have at least given me an opportunity to talk to you one-to-one directly. If you say I will do a THR in examination, that is wrong. It is not in good taste. It is not in the taste of academics. You are not a true orthopedic surgeon. तुम एक चीज़ को काट के यूं फेंक दो और सारी ज़िंदगी वो या एम्पुटेशन में जाएगा या हिप्पी करवाता रहेगा. इतने हिप रोज एडवेंचर नहीं हो रहे आपके, जस्ट यंग बॉयज. Now this is a Shan's has taught me. Read the literature. When there is appropriate age, Shan's can be neutralized again and then do a THR. We are not against THR or arthroplasty. We are in favor of long-lasting, age-old procedures that give patient a pain-free, stable, mobile hip that he functions. Not that he is with the hospital or in the hospital the whole life. So beautifully Shan's has taught me. I am demonstrating you. Patient has gained length. He will have mild limp, but his age is usually just 10 or 12 years when you do it. So that is not the age for arthroplasty. So the Shan's has taught me is an angular has taught me. Shan's has taught me is an angular has taught me. Change in length is a linear has taught me. Medialization, lateralization is a translational has taught me. So this is a translational has taught me. I have cut the bone here and medialized or shifted the distal fragment medially. It is called as translation has taught me. And angular I have just shown you. So just remember 4 types of osteotomies. So this is shifted medially. It is McMurray has taught me. So angular, rotational, shortening and displacement was translational. So various types of displacements are there. So 3 osteotomies you must remember, all the residents. Questions are going to be framed and asked about these 3 osteotomies in your examination. And if you answer a fracture neck of femur with the treatment with osteotomy, you are not going to fail. You are definitely going to pass. Two osteotomies in the same patient. I showed you yesterday, but I have fitted it for you for teaching purpose. So this is a oblique osteotomy. This black arrow means oblique osteotomy. Oblique. It is between 2 trochanters, lesser trochanter, greater trochanter. So it is intertrochanteric. So McMurray osteotomy is oblique, intertrochanteric osteotomy, and we displace the fragment medially. So it is a medial displacement. So McMurray osteotomy is medial displacement, intertrochanteric, oblique osteotomy, and because the weight is shifted from pelvis directly to the distal fragment, it's a pelvic support osteotomy. So it is a pelvic support, medial displacement, intertrochanteric, oblique osteotomy. That is the correct definition. So weight is going like that as per the arrow I have shown you. See, it's lasting the whole life. 50 years this osteotomy has lasted, and that's the osteotomy on the other side. And there is no limp. If you restore the body mechanics, biomechanics, patient is not going to have the limp. And you see how beautiful is the joint. Joint is maintained. वो कहते हैं ना, प्रत्यक्ष को प्रमाण की क्या जरूरत है? I have the videos of this patient at various ages and a follow-up of such a long, which no surgeon in the world, as far as the arthroplasty on both types are concerned, has. So that is a life example that these patients may not have limp, they may have a normal gait, the joint space is normal, and they never enter into arthritis unless there is something grossly wrong. So both the hips are lasting for 50 years. It's not a joke with osteotomy alone. That is the message I want to give to these youngsters. So this was the medially displaced. Each word I am clarifying every moment so that you go ready, prepared, as far as your examination is concerned, as far as this question is concerned in the examination. That is how the weight is shifted. And you see here, medial translation will cause you shortening in genu valgum. This is through diagram. So here, this is the center of the head of the femur, this is the knee, and that is the ankle. So when you do the medial translation, the mechanical axis is like this. So medial translation will cause you genu valgum. because mechanical axis has gone lateral to the center of the knee joint. So McMurray osteotomy, since we medialize it, causes genu valgum and causes shortening. That is the disadvantage of McMurray osteotomy. Causes genu valgum, it causes shortening. So in such a situation, you medialize the distal fragment so that there is no varus. Similarly, lateralization causes genu varus. If you cut it here and bring the distal fragment laterally, this is how the mechanical axis passes. So that will cause varus deformity. So when you do a valgus osteotomy, you do lateralization. So I've shown you yesterday, I'm not going to repeat it. And the only thing is that with McMurray osteotomy, because that was not fixed, the external rotation may be limited. Position of 4 may be difficult to make because of this thing. This is not working. So you see there is no limb, both sides operated. Nahi aa raha. So this is Shane's osteotomy, but here it is fixed with a contoured plate. Shane's osteotomy is an angular osteotomy. It is done at the level of ischial tuberosity below lesser trochanter. So it is a subtrochanteric angular type of osteotomy. And this is how the weight is transferred from the axial skeleton to sacroiliac joint to the proximal fragment, which is created parallel to the ilium. अभी बात करूँगा मैं आपसे थोड़ी देर में. So that is how the weight is shifted in Shane's osteotomy. So 3 osteotomies I talked to you: McMurray osteotomy, Shane's osteotomy, and Powell's osteotomy I talked yesterday. I will again talk. So this is, you see this girl, it was a Tom Smith disease. You know Tom Smith disease? The head is totally epiphysialized. There is total lysis of the head of the femur. Only a stump is left. That is again dislocated. So Shane's osteotomy is probably the best answer. You cannot do THR in these patients. And a split incision is given. See, she is grown now. She is married. She is a child. If she has some limp, this does not matter. So she had a fall in bathroom after 20 years and sustained a fracture, and replating was done. And she can squat above. Beautiful thing is, she can squat. The essential needs of our day-to-day function of the hip in Indian culture. She can fully squat, fully squat. And she has limp. I think it chal nahi raha. Mild limp, which we cannot correct. Powell's osteotomy, that you excise a wedge of bone, close the wedge, base is laterally, so varus will convert into valgus. You achieve your desired neck shaft angle, you gain the length and restore the body lever arm and muscular lever arm. These patients are not going to have limp. So pain-free, mobile, stable. That is the reason of popularity of this osteotomy, that you excise a wedge of bone and restore the normal biomechanics of the hip, which you are not likely to do with a McMurray's or with Shane's osteotomy. So I have told you that the varus osteotomy, when you do, you medialize the distal fragment. When you do a valgus osteotomy, you lateralize the distal fragment. That is the purpose of these sketches. See here. With markings I have shown you, this center, top of trochanter should be at the level of the center of the hip. So we have done a valgus osteotomy. So here A is the shortening. Trochanter should have been here. So what is here now? So this point has come down at the level of center of the hip, head of femur. So B. So A plus B is the gain in length. So patient has gained length. Compensated for shortening. And body mechanics is restored. And it has a beauty, this power osteotomy, that you don't have to open the fracture site. Powell used to open it, and Powell used to excise the fibrous tissue, do the osteotomy, and then give hip spica. So today we are not giving any spica. So here we did a closed type of a laterally based wedge osteotomy, abducted the distal fragment, and this two patient has 25-year follow with me. How beautifully the gap is filled with bone. No grafting is done. So that is the beauty of this procedure. And why should we not think of these biological procedures which are lifelong lasting and see the beautiful joint? And it is published. It is not an unpublished work. I have published in CORR, Clinical Orthopedics Related Research, an ally of JBJS, the world's top journal. So kindly accept these things academically and in the interest of patients, and learn osteotomy. Osteotomy is very simple. If you can do THR, I think THR is difficult. But this is very simple procedure. You have more and more workshops. I request the teachers working in medical colleges and senior surgeons to start doing it, to perform it. Though there is no awareness. A lot of people are asking me for doing workshops. अभी 2 महीने पहले मैंने कोटा में वर्कशॉप की है. अभी मैं during this Iatscon में करूँगा. They have invited me again. I never asked them to ask me, but they think it is the need of the time. And thank you, Ranjit and Bhaman and all the your Sandeep and all these people with Sudhir Kumar and all, that you have invited me and for a session on hip, especially on the examination also. So this is 16 years follow-up which I have published. I have 22 years follow-up of this patient. See how beautiful collapse is there. Neck length is there. Yes, you can put a fibula. I was asked a question, when do you put fibula? But there was no space for me to put a fibula here. And it healed very well. You can do lengthening. See here, the osteotomy is done here, and then this fragment is dragged laterally towards the plate. Plate is kept out. So the limb has gained in length. See this is the beauty. This was Coxa-Vara acquired. इस बच्चे के फ्रैक्चर नेक फीमर था 1986 में. इसके 5 ऑपरेशन हुए हैं. 5 surgeries for this child. The trochanter was elevated, the hip was short, the neck was short, patient developed some arthritis. When he was in the age of 19 years old, when he came to me for the 5th surgery, and I did only valgus osteotomy. ये देखो, ये मैंने valgus कर दिया यहाँ से, और यहाँ से जो wedge था मैंने यहाँ निकाल दिया, और इसको मैंने lateralize कर दिया. So this is example of medialization, lateralization. Maybe this case is there, I will show you. So these are the valgus varus 2 osteotomies and further revision, flexion, extension. So valgus can be V, it can be Y, it can be extended Y. Powell's osteotomy were talking to me. V. Now this is a V-shaped wedge. So Powell's V osteotomy, I will say. Any question from the residents? It is basically being done for you. So this is simple V. Apex is medially. I am writing my book. All this I have included. You will not get this classification in literature. This is Y. So one limb, vertical limb. The Y osteotomy. So in V there will be some shortening, in Y there is no shortening. One limb, second limb. This is extended Y osteotomy. This is Y again, V and this is Y. And you extend it further, it will be extended Y osteotomy. So this is extended Y osteotomy. When head is small, you cannot fix screw, and the fashion of these days PFN. So you do osteotomy when head is small in size. Yesterday Ravi was talking. I think Ravi was talking about classification. See, it is buttressed from below. So this is extended Y osteotomy. Ye Y, ye V or ye Y or ye extended Y. Just 22 years, married girl, first delivery, had a eclampsia, and because of the fit, she had this fracture. It's a beautiful union. Of course, this girl developed later on AVN. So male united fracture, bilateral. Again the indication is Powell's valgus osteotomy. आप मुझे रोक दीजिए जब आप थक जाएं, मैं तो नहीं थकता. बाकी भुवन सिंह याद रखेंगे, फ्लाइट नहीं निकल जाए. So various conditions again. All these cases have been shown to you by Dr. Ananda Pal. Very nice, thank you. Coxa-vara, leg Carvey's Perthes disease, FAI, femorostabular impingement, slip epiphysis you showed. So in all these cases, Powell osteotomy is very useful. Except Coxa-vara, yes, again, we also do valgus osteotomy here. Not Perthes. In Perthes, we do varus. And in neglected, we again do Powell's. 70-degree angle. And I showed you CT scan of this patient. On MRI, you will find broad epiphysis, verticalization of the epiphysis here. This is not going to heal unless you horizontalize. And that is what Powell said, that you horizontalize the pseudoarthrosis, bring it at right angle to the body forces R. Ye forces R aa rahi hain, ye. It will heal. So laterally based wedge 50-degree, ये स्लाइडें मैंने 2008 की बनाई हैं क्योंकि पेशेंट ही 2008 में ऑपरेट किया था. So my lifelong work, and I'm happy that I am sharing with you to teach you people. And I show follow-up to you. You will not get such things in book. You may read Campbell or Turek or anything, unless it is my chapter. In my chapter, you will get a very long follow-up. In Turek also I have given, but this follow-up is with me. And all those papers which I have published, the recent follow-up is with me. 5 years. And very interesting, for the sake of pension, this girl did not get surgery of this hip. कि सर मैं handicap हो गई हूँ अब. पहले तो सिर्फ डक गट थी, इसकी वेडलिंग गेट थी. I was telling Ravi, is he here? Ravi Chauhan is here. I was telling him yesterday. Now interestingly, after 16 years, she came to me with a mithai, with sweets. सर मेरी नौकरी लग गई, मैं हैंडीकैप थी, अब मेरा दूसरा हिप कर दो ऑपरेट. That is the beauty of osteotomy, sir. For normalization, they come to you. Coxa-vara, this girl came to me only for wedding purpose. It is truth. I said, यार तू 20 साल की होगी, अब तक चल रही थी तो अब क्या है? नहीं सर मेरी शादी नहीं हो रही. You see, this is Coxa-vara, acquired. So I excised only a wedge of 20-degree. और मैंने बहुत डरते डरते किया. मैं कहा तुझे और लचक होगी तो क्या करेगी? So at her risk, I operated this patient, made it 130, and she has no limp at all. She walks limp-free. Osteoarthrosis itself In this country, we have secondary osteoarthritis. So you read Bombelli's book, he will show you many hundreds of cases of primary osteoarthritis, wherein he did a osteotomy and patients become stable, mobile, pain-free. So Bombelli's work should be remembered. So 6 months follow-up and 14 years follow-up. You see the nature has increased the weight-bearing dome. So once, and that's the purpose of osteotomy is also, so there is a traction on the capsule to convert into bone, and weight-bearing areas increase. So per unit area, the stresses are decreased, and osteotomy has served the purpose. This person became pain-free with stability of the hip. In spite of having already arthritis, he worked very well. Slip epiphysis capitis femora, healed one. I told you classic deformity. I asked you purposely 3 deformities: external rotation, adduction, and extension. So you do neutral rotation, so you do flexion, and you do abduction. So power osteotomy works very well. Correct the deformities at the osteotomy site. A beautiful indication. OA hip. So bring a weight-bearing, healthy area of the head of femur. Patient will be pain-free and heals. You see? Fibula I put in below, from below. Fibula, see? 385 weeks means 7 years. He can squat. This is the floor of the corridor of my department, orthopedics department. He is an air conditioner mechanic. Now doesn't come to me, sir, मैं ठीक हूँ. बड़ी कोशिश करता हूँ, एक आ जा यार, एक follow मुझे चाहिए. 10 years. See the osteotomy, this fibula is taken very well. बस खत्म करो. हाँ बस. See one, osteotomy creates bone. This is what I want to tell you here. See, this is a pathologic fracture. Fibrous dysplasia, neocurettage. कोई curettage नहीं किया, कोई bone grafting मैंने नहीं की. इसको osteotomy ने ही हील कर दिया सिर्फ. और ये भी पब्लिश केस है, ये CORR में है, 2005 के अंदर पब्लिश किया. See the beautiful healing. Simple bone says, thank you very much. Thank you. हाँ 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 बस मैं बंद कर दिया. आपका हुक्म चाहिए. देख लो आपने, हम तो खत्म ही नहीं होंगे कभी.
तो पता है मुझे.
सारी रात चलते रहो. सर वो भी पूरा नहीं होगा, अभी कोशिश कर रहा हूँ. बेटे ये कोई चीज़ मेरी रह नहीं जाए.
So by the time we are arranging for the workshop tables, by that time we will be having some basic aspects by Ranjit sir. Sir, please.
बहुत अच्छे. Thank you for inviting. Grateful to you. पढ़ाने में मजा आता है. वही तो है. बहुत है मेरे पास. शॉर्ट में नहीं, बहुत में से भी बहुत है.
अच्छा ठीक है, अभी आगे तो बहुत है सर.
लिया बेटे.
मेरा निकाले हो. Good morning. There are so many slides, but I will stick to a few only, just to make the pieces aware how to plan and how to do, and what is the basic. What is the basis of. So, nothing to say much about all this. This is about degrees, 1, 2, 3 Powells. Hmm? So, why does it happen? Shear forces, we have to convert it into compressive forces. How? Uh, we'll discuss it. So, injury to the capsular arterial blood supply to the femoral head, capsular tamponade, all these things, absence of cambium layer, and by doing osteotomy, with this is a winning of biology, biomechanics, and bone quality combined together leads to what we desire, the union. Uh, Nothing much about that. Displacement osteotomy is already discussed. Causes gross distortion. Angular osteotomy is more successful, and we are going to discuss about VITO, valgus intertrochanteric osteotomy. The general principles of VITO was first laid down by Frederick Powell, popularized by Muller. Several modifications were also described by Miller. I will show all these types. So, this is from Muller's original work. This is the basic. Everyone of us has been doing it. We still do it. It's a very successful one. So, the another osteotomy, when a valgus wedge prop osteotomy is indicated when the fracture is nearly vertical, when there is minimal varus deformity, or when the femoral neck is fairly long. How to plan your wedge, we will discuss later. So this is, you can see the cut is more, both the cuts are a bit oblique, and the lower one slips under the fracture. This is wedge prop osteotomy. Next, a valgus or bicep prop osteotomy when the cut is made into the fracture itself. So this is for the severe varus deformity. And then again, it is very, very severe deformity. You have to go very up for removing wedges, and this is transposition osteotomy as described by Muller. Shear forces lead to the collapse. VITO helps by making the fracture plane more horizontal and moves it closer to the axis of the load transmission across the hip joint, thereby converting the shear to compressive forces. Just like that. Why 25 degree is deducted from the whatever Powell angle we have measured? Because the weight bearing forces make an angle of 16 degree from the vertical, and the femur is 6 to 10 degree, and on an average 9 degree varus towards midline. So combined together, on the femur the forces are acting at an angle of 25 degree from the vertical. And what we have to do, we have to make the fracture line perpendicular to the forces, so that shear forces are converted into compressive forces. So that 25 degree, somewhere 20 degree they also call it, you have to remove it. You have to deduct it from the whatever Powell angle you have measured. Measuring Powell angle is diameter, line across tangential to the fracture line. The angle it forms with the horizontal is the Powell's angle. So how to measure this? If suppose for example 45 degree is your Powell's angle, subtract 25 degree, general principle, and the 20 degree is the wedge you have to remove. Now how to remove? Now all the bones are not same. Some bones are thicker, some are narrower. So, what you have to do? Angle into 0.02, angle into 0.02 into the diameter. And that will be the base of the wedge. This is very important because all bones are not the same. You have calculated I have to remove a 25-degree wedge. So, on the table, pass a drill on the desired osteotomy side and measure the diameter of the bone. To that, whatever degree into 0.02, whatever comes should be the base of your wedge, and that will give you the exact angle. Always remember it. Oh, the same thing, how it works, how it happens. Once the fracture plane is subjected to the continuous compressive forces, the fibrous tissue is rapidly forces are like coming to, you have to usually a transverse cut over here and then wedge. Suppose x degree, but measuring that x degree, you have to measure in centimeters or millimeters. So that angle has to be converted into that amount of centimeters so that if that amount of wedge is cut, the angle is 25 or 20 or 30, whatever you have planned for. So you have to pass a drill over here, measure that amount, that measurement should be multiplied by angle into 0.02, and that will give you the exact amount of wedge base which you have to remove. Now where from? Classically we do from here. We can do from lower down also. Same thing will happen, the valgization. It will become valgus, but the chances of union are less because the bone becomes cortical. So ideally, it should be from here. The same thing in principle, 25-degree make, this is the, one is axis of the femur, make a 25-degree to this, to a 90-degree, and then whatever angle it makes with that, that is the exact amount of angle which the wedge, that amount of wedge you have to remove. Indications I am not going into it. Established femoral neck pseudoarthrosis, delayed presentation, primary veto, sometimes people are doing it. Absolute contraindication is establish avascular necrosis and relative or advanced age, smoking, osteoporosis, a small femoral head. That is very important. If the head is very small, neck resorption ratio, very important. Measure the neck length of the contralateral healthy hip. If the amount of, that may be debatable, but that is a general recommendation. If the amount of neck which is left is less than 52% of the contralateral, it should not be done. That is called neck resorption ratio. So, for accurate templating, we need to know amount of correction needed. Powell's angle minus 25-degree. Osteotomy should begin at 1.5 centimeter below the site of blade insertion. Why? Because a good amount of bone should be there, otherwise that will fracture or your construct will become unstable, leading to failure. So, this is how we measure and how we do the pre-operative planning with the 120-degree blade. The blade insertion angle is calculated based on the supplementary angle. What is supplementary angle? Suppose you are for a normal DHS, what we do? 135-degree DHS we are doing. So we put our guide wire at the 45 degree. So if I put my guide wire at 45 degree, what will happen? It will fit flush on the surface. We won't be able to correct it. So one has to add the amount of correction needed to this supplementary angle, and the guide wire should be placed on as per this angle. Supplementary plus which angle that is required. The chosen blade plate is inserted fully into the neck. At this point, the blade plate stands off the shaft, which can be brought to the shaft by breaking the medial cortex and abducting the limb. The distal limb of the plate and the femoral shaft can be clamped together. And one thing important, so many people, what did they try? They try to bring the shaft to, plate to the shaft. Never do that. Bring the limb to the plate. And initially, the distal end of the plate will come into contact with the shaft. First, insert the distal most screw and then gradually come proximally. What will happen? It will produce a compression across the osteotomy site. I am again repeating. Suppose this is the shaft plate. Don't try to bring the plate to the shaft. Just abduct it, so this will be like that. First distal most screw, next screw, लंब और कर्ण है. एक ये लंब और ये कर्ण है. जब दोनों बराबर हो जाएंगे तो ultimately what will happen? That will, the kern is shorter, kern is longer, lump is shorter, come together, the kern becomes lump, and what will happen? That will compress the fracture site. If at all there is less compression, you are not happy, you can use, if your plate has dynamic holes, that will also help you, or you can use Mueller devices also. Blade plate, it is preferable, remove less bone, leave a small footprint, and offer better rotational stability. Double angle blade plate causes undesired medialization. So nowadays, double angle for majority is not preferred. It should be avoided because it unnecessarily medializes the distal fragment, leading to mechanical axis passing through the lateral compartment of the knee, leading to later OA changes in the lateral compartment of the knee. And then it, because by producing valgus, we are decreasing the offset. Further medialization further decreases the offset. So, double angle should be avoided. So we have all intertrochanteric osteotomy already described, subtrochanteric osteotomy. Osteotomy can be done at the subtrochanteric level also, but the problem of healing is there and difficulty in controlling the proximal fragment due to muscular forces. And then there are different types of like half or half-wedge osteotomy, no-wedge osteotomy, where only translation is done. So forget about it. We will concentrate on the normal wedge osteotomy, closed wedge osteotomy, where how to remove it, how to measure it, and how to perform it. We have already discussed it. Problems on complication, medialization soft, excessive valgus, AVN, yes. Don't make too much valgus. Ideally, it should be just more than 15 degree of contralateral. It has been seen if it is more than 15 degree, chances of AVN are more. And to have this femoral offset don't get much reduced, never use double angle. Or if you at all using a double angle implant, try to keep it proud. Don't flush it on the surface 10 to 15 mm away from the surface. So in that situation, even your double angle will act like a simple DHS or simple blade and plate. So we are not going to discuss this. These are a few examples. We are not already so many things. So thank you. This is about how to perform it. Thank you.
LT के दिख रहा है LT ये बड़ा कर दिया एक आगे जी छोटा कर दिया
हो जाएगा करिए सर उससे कोई दिक्कत नहीं
ओ
वहीं तक जाएगा ट्रांसवर्स ले रहे हैं सर ट्रांसवर्स ले रहे हैं वायर गाइड वायर अभी ध्यान रखो
ये 1.5 रहना चाहिए या वास्टस लैटरालिस रीज से 1.5
सेंटीमीटर नीचे
X और Y whatever सेंटीमीटर सपोज 2 सेंटीमीटर अब क्या करेंगे
थोड़ा सा फैला दो
आपको एंगल कितना निकालना है आपने पहले से मेजर किया हुआ है आपका 55 था क्या पावेल्स एंगल -25 comes to 30 so you have to have a 30 degree correction you need to a 30 degree correction अब ये 30 डिग्री करेक्शन के लिए 2 mm का आपको मान लीजिए कि ये सेंटीमीटर का आपको मिल गया 2 into 30 into 0.02 काउंट करिए कितना होगा
60.0 से आप कर दिए 1.2 सेंटीमीटर
उतना ही आ रहा है श्योर 2 पड़े अब इसका तो हम नापे नहीं है या नाप लीजिए जरा इसको कैसे नापेंगे
स्केल इसके ब्लेड के स्केल से नापाएं
नहीं तो इसको ये खोल ये वाला नहीं ना है तो इसे कितना आ रहा है 40 तो 40 into
2 पहले
अभी ये 40 into 30 40 सेंटीमीटर 40 mm हो गया ना तो 4 सेंटीमीटर into 30 into 0.02 कितना हुआ
तब तो ज्यादा हो जाएगा
यही होना चाहिए जनरल फॉर्मूला इज 1 mm फॉर तो 30 के लिए कितना 3 यही जनरल फॉर्मूला है बट दिस इज फॉर एन एवरेज 58 के थिकनेस के लिए है
ये ज्यादा जब
लेकिन अगर आपका थिकनेस ज्यादा है ऑल बोन्स आर नॉट द सेम एक लेडी का है एक हैवी मैन का है तो इस हिसाब से आपको एग्जैक्ट नहीं हो पाएगा। आप तो वेज में नापेंगे, आप डिग्री में थोड़े नापेंगे। आपको वेज कितना निकालना है, तो ये आपने डाल लिया। अब एक कट यहाँ वर्टिकल कर लेंगे, तो कितना निकला आपका 2.4। अब 2.4 नापिए यहाँ से, जहाँ पड़ा है, मान लीजिए यहाँ पर आ गया, उसको एम करेंगे फिर वहीं पे। ये तो इमेज हम नहीं है मेरे पास ना।
सर इसका तो कोई गाइड होना चाहिए। एग्जैक्ट एम करना भी टफ है।
एम तो आप आराम से कर सकते हैं। नहीं तो आप तो यहाँ पर एक वायर रख दीजिए, इमेज आपके पास है, हम तो बिना इमेज के काम कर रहे हैं।
वायर को हम लोग रहने देते हैं, निकालते कहाँ है, इसीलिए तब समझ में आता है कि हाँ वायर नहीं है।
तो एंगल तो हमको देखना नहीं ना है, हमको तो डिस्टेंस इतना नाप लिए। वेज का डिस्टेंस इतना हो गया 2.4। मान लीजिए कि हमको स्केल नहीं ना है, वी डोंट हैव स्केल।
स्केल है क्या का प्रवीण जी?
स्केल से यहाँ से 2.4 का आपको
यहाँ आ रहा है सर।
तो वहीं तो हम मोटा मोटी वहीं पर हैं।
अभी 2 सेंटीमीटर में आप हैं एग्जैक्ट।
चलिए 2 सेंटीमीटर तो 20 का कटेगा, या जो 2 सेंटीमीटर पर काटे, जो भी काटे, प्रिंसिपल
सब दोनों का जो मर्ज एकदम होना चाहिए।
तो मर्ज होना ये चाहिए। तो आपने वर्टिकल कर लिया, दिख रहा है आपको। अब फिर आपने वेज कर लिया। इमेज में कैसे करते हैं आप? वही निकला कि नहीं निकला? अंदाज से ही वही निकल गया। अब ये पर दोनों को 100 से काट लेना है। लेकिन ये तो वेज निकालने का मैंने पहले शुरू किया है ना, हो गया। अब इसको कुछ जरा खोलो, कहाँ है इसका? ये
ऐसे ही खुल जाता है सर हाथ से।
ये हम नहीं जानते हैं इसको, कभी यूज ही नहीं किया। अब हो गया वेज तो ये, लेकिन बिफोर दैट एक और गाइड वाइड दीजिए। आपके सामने क्या है? जीटी। कहाँ पर रखे? इमेज दिख रहा है, एम करना है। तो एक कोई भी जब हम लोग डालते हैं कोई एनीथिंग, डीएचएस जो भी, तो उसका एक एंगल होता है 135। उसके लिए सेंटर में एम करते हैं। तो एक जनरल प्रिंसिपल है कि इसके एलटी से इससे नीचे, जैसे यहीं से हम लोग एम करते हैं तो कहाँ पहुँचता है? सेंटर में। एंगल ये क्या रहता है? 135। तो कितना? 45। जो आप लगाते हैं आपको लिखा रहता है 135 के लिए, लेकिन वो एंगल 45 का बनाता है। दैट इज कॉल्ड सप्लीमेंट्री एंगल। सप्लीमेंट्री एंगल। तो सप्लीमेंट्री एक हाई इम्प्लांट का फिक्स है। सपोज कि हम यहाँ पर डबल एंगल, तो मैं आई एम डिक्राइंग इट, तो 135 का ही मेरे पास डीएचएस है, उसको हम यूज़ कर रहे हैं। यूज़ करिए, कोई दिक्कत नहीं है। अब 135 का सप्लीमेंट्री एंगल कितना हुआ? 45। और उसमें हमको 30 डिग्री का करेक्शन चाहिए, तो 45 + 30 75। अब यहाँ पर 75 पर डालेंगे। यूजुअली आप देखिएगा, यहाँ से आप डालेंगे, यहाँ से नॉर्मल में तो यही जाता है। तो यहाँ से आपको ऐसे जगह से डालना है कि वो 75 के एंगल पर जाए। तो मान लीजिए हम 75 के एंगल पर हैं, अब दिख नहीं रहा, कहीं निकलेगा। निकला?
आ गया एकदम सही जगह। ठीक सर, आ गया सर।
अब क्या है? मैंने डाला कहाँ? देख रहे हैं आप कि इतना चौड़ा है। आप यूजुअली यू विल हैव ए टेंडेंसी टू पुट इट फ्रॉम हियर, लेकिन जब ये डालेंगे तो नेक देखिए कहाँ है, you can splinter the posterior neck. कर सकते हैं. So आपको उससे अवेयर रहना है. Posterior neck is very important. और यहाँ पर आप कुछ भी करेंगे तो you can injure the vessels also. तो वो नहीं करना है. आपको ये देखिए, ये ऑलमोस्ट फ्लश है इंटीरियर से और ये इतना एरिया छोड़ के है. सो 2/3 के बीच में डालना है. पोस्टीरियर 1/3 को छोड़ देना है. तो दैट मीन्स इंटीरियर 1/3 एंड पोस्टीरियर 2/3 के जंक्शन पर ये डालिए. तो यू विल बी डेड इन द, यू विल बी इन द सेंटर, इनटू द dead center of the head in the
lateral coronal plane.
Inferior part of the head in the center in lateral or in AP lower part of the head. अब ये आपने डाल दिया. इस पर आपको चीज अपना बना लीजिए. पहले क्या करेंगे? पहले या तो आप नहीं है इम्प्लांट तो आप इसमें चीजेल डाल देंगे. चीजेल है,
देखिएगा इसको बचा के रखिए.
चीजेल को हैमर कर देंगे. चीजेल को, उसका चीजेल को, चीजेल वहां तक चला गया. चीजेल को अब निकाल लिया.
थोड़ा सा इसे कट कर लीजिए सर. नहीं इसी से पहले शॉट थोड़ा चला देते हैं.
यहीं पर लो हैमर दो. चौड़ा है लेकिन ये तुम्हारा
चीजल थोड़ा पतला होना चाहिए.
थोड़ा पतला होना
12
चाहिए.
mm 13 mm बस. ये 15-16 mm वाला है.
छोड़ दो रह गए. उस समय अगर आपको दिक्कत कर रहा है तो आप इसे काट लीजिए. है कि जब आप ऐसे करेंगे तो ऐसे हो जाएगा. तो डायरेक्शन
काट ही देते हैं.
काट इट.
थोड़ा सा काट देते हैं.
पूरा इतना काट लो. आधा से काट दो. अब आइए. अब इसको प्लस करके, है ना, ये अगर अब डबल एंगल सीखना चाहते हैं ब्लेड प्लेट तो देख लीजिए. ये ऐसे नहीं रहना चाहिए, ये ऐसे नहीं रहना चाहिए. क्योंकि जब आप प्लेट डालेंगे तो प्लेट या तो आपका इधर चला जाएगा या इधर चला जाएगा. तो इसके एक्सिस से 90 डिग्री पर रहना चाहिए. पकड़ो जरा, उधर से सपोर्ट करो.
और सर आपका हाथ आ गया है इधर इंटीरियर
ना ठीक है. ना ठीक है. ओह सॉरी, ये उड़ गया.
नहीं बचा.
कोई बात नहीं, उसमें दम नहीं है. वो जाएगा नीचे, वहाँ मैं चला गया. छोड़ो, हटाओ.
सोच लो कि ऐसा हो सकता है.
वो इसमें नहीं होगा. इसमें तो ये नहीं दम हो तो क्या करोगे? तो हर जगह हार्ड है.
TBW सामान ऐसे सारा रेडी रखना.
नहीं तो
ध्यान से सामानवा रखना पड़ेगा.
हम तो वैसे ठीक ही जा रहे थे. चले यहाँ से डाल देते हैं.
शॉप से डाला जाए. शॉप पतला भी है और पता नहीं काटने 100 तो ऑसिलेट करता है.
जगह का मोड़ रहेगा.
हल्का रखिए. काट देगा.
देखा तेरा
प्रैक्टिकल इतना आसान दिखता है. हर काम
पकड़ रहा. सब इतना नहीं हिल रहा तो बॉडी पर क्या. ठीक है, बात समझ गए कि आपको यहीं पे काटना है, यहाँ तक पहुँचा देना है चीजेल को. और अगर केवल इसी पर करना है तो काम तो खत्म है. उठाइए अपना रिमर, ट्रिपल रिमर से कट करके DHS को डाल दिया. अब क्या हुआ? DHS ऐसे तो 135 का लगाएंगे तो ये फ्लश हो जाएगा. लेकिन हमने तो क्या, इसको तो 30 डिग्री बढ़ा ही दिया है. तो ये DHS ऐसे रहेगा. उसके बाद इसको दोनों को आपको 100 को काटना है. लाइए, है तुम्हारे पास ये DHS का सामान लाए हो, तब होगा कैसे? आधा से कैसे काम होगा यार?
एंगल ब्लेड प्लेट है.
हम कैसे उसको बनाएंगे? कुछ भी काटने का रिमर वगैरह दीजिएगा ना. इतने से हो गया. एगो प्लेट ला दिए, एगो ला दिए, बात खत्म।
नहीं, इसका ये भी, और उसका ब्लेड प्लेट डालने के लिए स्पेशल उसका ऑस्टियोटोम होता है, जिसमें कि उसी तरह का स्लॉट होता है उस ऑस्टियोटोम में ब्लेड प्लेट डालने के लिए।
ब्लेड प्लेट ऐसा होता
सेम
है,
रहेगा जैसा ब्लेड प्लेट का प्लेट रहेगा वैसे।
Why blade plate is better than DHS? Why? Because it gives a better rotational stability. Why? Because there is एक तो plate portion है जो कि that will sit flush on the surface of the bone on the lateral aspect, and then there is a
ग्रूव दोनों साइड से ग्रूविंग है।
blade portion. Blade side में फिर एक ऐसे ग्रूव रहता है, वो जाके फिर रोटेशनल स्टेबिलिटी देता है। और अपने में तो ये ऐसा है ही कि ये इस पर nothing will rotate. Apart from that, there are two edges, two flanks on 90 degree, और वैसा ही वो चीजेल रहता है। तो वो चीजेल वंस जैसे इसके तरफ उड़ा वो वैसे ही चलता जाएगा, डायरेक्शन ठीक होना चाहिए,
सीधा मारना है एकदम,
और उसको
इसी में रख के,
हाँ
ऐसे ही रख के मारना है।
और उसमें हमेशा कि इसका जो फेस है वो this makes an angle of 90 degree perpendicular। थोड़ा सा भी यह रहेगा तो जब आप ऐसे हो गया,
उधर काट दीजिएगा,
ऐसे हुआ, थोड़ा भी ऐसे हो गया। लेकिन ये प्रॉब्लम इज नॉट गोइंग टू हैपन विद DHS। दैट्स वाई मेजॉरिटी ऑफ पीपल लाइक DHS और DCS। क्यों? स्क्रू को थोड़ा सा ऐसे घुमा दिए, प्लेट अपनी जगह पर फ्लश हो गया लेटेस्ट। दैट इज द एडवांटेज ऑफ DHS ओवर blade and plate, in spite of the fact that the blade and plate is a better implant than DHS because of providing better rotational stability. क्लियर सबको?
ब्लेड प्लेट में जो फिर डबल एंगल आया उसके चलते फिर जब देखा गया कि नहीं है, फिर DHS भी डबल एंगल में आ गया।
तो अब DHS, तो अब इसके बाद इसको हम लोग सपोज की
सर बहुत खराब है सर, बचा के
सामान्य नहीं दिया तो हम क्या करें, है ना? इतना पर ही चला गया ना, देख रहे हो ना, ये इतना पर चला गया। अब यहाँ से काट के तो सामान
डिजिटल साफ्ट को ही आपको बाहर, साफ्ट को ही लाना है बाहर।
हाँ, अब काट,
जब सब प्लेट वहाँ सब रख लिए तो
अब कट भी नहीं करेगा, सामान ही नहीं। क्या सामान तुम दिए हो?
सर इसको काटते हैं सर।
अच्छा काटो काटो काटो, तुम ही काटो, काटो, हमारा इंजरी हो जाएगा। नहीं लेकिन सामान आप ये इतना से थोड़े होता है, तो फिर हम DHS के, आपके पास ब्लेड प्लेट कहाँ है? अच्छा आपने DHS ला दिया, वेयर इज द DHS को लगाएंगे, घुसाएंगे कैसे हम? DHS घुसेगा नहीं, DHS तो लाने को बोला गया था ना, क्या बोला गया था? अच्छा काटो काटो काटो, अच्छा उड़ गया ना, अच्छा वेज काटो ना, वेज काटो, वेज काट के दिखाओ। अच्छा इनको काट लेने दो तो मैं वेज के बारे में एक बताऊं। कट गया, देखिए अब ये तो हाँ, इसको कुछ करने का, छेद करने का कुछ है हमारे पास? ना ना, इसको कुछ
हाँ इसमें लगा देते हैं सर, हो जाएगा सर। रुकिए सर, ड्रिल बिट होगा ना, ये ड्रिल बिट, ड्रिल बिट को नहीं मिलेगा, लाओ खाली वो ड्रिल बिट लाओ, 4.5 अभी तो बहुत
अरे घुसाते हैं,
एक ड्रिल बिट लाए ना, हो जाएगा सर। ड्रिल बिट मंगा
इसको ड्रिल कर देते हैं।
कैलकुलेटेड ड्रिल बिट नहीं मिलेगा, प्लेन खाली फैला देंगे।
कुछ लाया ही नहीं है तो हम क्या करें? निबलर है जी, निबलर, निबलर लो।
नहीं ड्रिल बिट दे दीजिए, नॉर्मल ड्रिल बिट दे दीजिए ना, हो जाएगा। नॉर्मल ड्रिल बिट लिया जितना मिल जाए।
पहली बात, अब वेज तो कट गया, जो भी कटा है थोड़ा सा तिरछा कटा है ना, कोई बात नहीं, अभी अभी मत करो, फिक्स मत करो अभी।
फिक्स कर देते हैं सर, उधर करिएगा तब तो हिलते रहेगा, कैसे होगा सर काम?
क्या है फिक्स, क्या है कर रहे हो अभी?
सर हिलते रहेगा सर फिर।
अभी रखो ना नीचे, हमें दो बात और बोलनी है।
अच्छा
जब आपने ये लगा दिया, एक यहाँ पर गाइड वायर, आपका वेज का उसका दोनों का डिस्टेंस नाप ले लिया हमने, तो आई हैव चेंज्ड इनटू अ डिस्टेंस, सम लीनियर मेजरमेंट, एंगल, proposed angle. Suppose the Powell's angle was 45 minus 25, और अगर 55 तो minus either 20 or 30 हो गया। उतना का हमको करेक्शन चाहिए। फीट सेंटीमीटर में मैंने उसे कैसे कन्वर्ट किया, यहाँ पर एक ड्रिल देखा, उसको मेजर कर लिया, मेजर्ड इट एंड देन that into angle into 0.02, जिंदगी भर के लिए याद कर लीजिए। अब ये जो डिस्टेंस मिला, उसी डिस्टेंस पर एक गाइड वायर ऐसे जो कि LT के ऊपर जाए, एकदम सीधा LT के ऊपर ट्रांसवर्स, और एक नीचे से जहां जाकर वहां पर मीडियल कॉर्टेक्स पर मिल जाए। नाउ फिर अब इस मेजरमेंट को नापिए कि क्या आपने जो किया है, वॉट एवर यू हैव डन इज एग्जैक्ट और नॉट। इट मे बी ए बिट मोर और मे बी ए बिट लेस। तो आप करें क्या कि नीचे वाले, ऊपर वाला जो डाला है ना, उसके नीचे से डालिएगा तो ऊपर की तरफ नहीं भागेगा, क्योंकि ऊपर की तरफ भागेगा तो देन वी विल फॉल इन ट्रबल, क्योंकि वो नेक में घुस जाएगा ना। तो बस गाइड वायर के नीचे से उससे सटाते हुए, इमेज में देखते हुए कट करते चले गए, ट्रांसवर्स कट, और जस्ट स्टॉप शॉर्ट ऑफ मीडियल कॉर्टेक्स। यू हैव टू स्टॉप शॉर्ट ऑफ मीडियल कॉर्टेक्स, बिकॉज देयर यू हैव टू डू ए osteoclasis, not osteotomy. And then the same way, जो नीचे वाला है उसके ऊपर से, और अगर आपका थोड़ा कम है तो उसके नीचे से, क्या कि वो आपको ऊपर फिर जाने नहीं देगा, सटाते हुए काट दीजिए। तब तक आप ही कर दीजिए, ठीक है, वेरी गुड। तो आप वो कर लेंगे, और जैसे मीडियल कॉर्टेक्स के पास आपका 100 जाता है, stop short of that, leave it, remove the wedge. But before that, आप क्या करेंगे, आप इसको जो अभी डॉक्टर साहब ने बनाया, बन गया, तो इतनी बातें स्पष्ट हुई या नहीं हुई? क्लियर एवरीबॉडी? एनी कंफ्यूजन रिगार्डिंग एनीथिंग, यू कैन आस्क questions, you can get it well explained again by me. किसी को कोई हेलो 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 एनी क्वेश्चन? ठीक है,
देखिए इसमें DHS का ट्रिपल रिमर बनाने भर जगह आपको बनाना पड़ेगा, ताकि आउटर चौड़ा करना पड़ता है। कितना है जी DHS का बैरल का, कितना थिकनेस होता है? 13.5 13.5 mm। कोशिश करने से थोड़ा बना है।
देर साला रिमर दिया ही नहीं, अब ये आ गया, हमने घुसा दिया। जबरदस्ती क्या कॉम्प्लिकेशन,
एक्स्ट्रा पावर।
आप हमारा यही है। तो क्या करते हैं भाई लोग, यहाँ पर एक बोन क्लैंप लेते हैं, इसको दबाते हैं।
नहीं,
डोंट डू इट,
डोंट डू इट,
है ना। इसको
लेग एंड को बाहर,
लेग को बाहर एब्डक्ट करते जाइए। तो यहाँ तो नहीं है तो हम इसी को एब्डक्ट करते जाते हैं।
ये और बैठेगा, ये प्रॉब्लम है, इसीलिए डबल बैंग उसमें सपोर्ट
नहीं, इसको अभी और अंदर जाना है। हाँ। इसी प्रॉब्लम के लिए तो डबल एंगल लगाते थे। तो अब क्या करें हम,
सपोर्ट नहीं हो रहा था,
ये इधर से एंगल ठीक पर नहीं गया है ना, एंगल पर ठीक से नहीं गया, लो ना, ये एंगल पर गया ही नहीं है ठीक से। तो अब हम जो करेंगे ये ऐसे हो गया। अब देखिए एक ट्रायंगल बना हुआ है ना, क्या बोलते हैं उसको, कर्ण का अंग्रेजी क्या होता है, व्हाट डू यू कॉल दैट, लंब कर्ण आधार, बेस परपेंडिकुलर, और एज पे क्या बोलते हैं उसको, हाइपोटेन्यूज। तो हाइपोटेन्यूज इज लॉन्गर देन द perpendicular, this is perpendicular, this is hypotenuse. now एक स्क्रू यहां डाल दीजिए, नहीं ये हाइपोटेन्यूज हो गया,
ये
तो
हो गया।
हाँ हाँ, तो अब हाइपोटेन्यूज हु हैज टू एडजस्ट विद इन द कन्फाइंस ऑफ परपेंडिकुलर, तो नेचुरली देयर विल बी कंप्रेशन एट द फ्रैक्चर साइड। इसीलिए इसको आप अभी तो हम ला नहीं ना पा रहे हैं,
हाँ तो हम लोग इसी को फिलहाल लाएंगे।
वो तो
नहीं ठीक है, हम लोग अभी इसको लाएंगे।
हाँ, तो ऐसे ऐसे सट गया ना, देखो सट गया। अब क्या हुआ,
अब एक जो प्रॉब्लम
अब
होता है वही ट्रांसलेशन
इसको इसी डिस्टेंस में, तो पहला ये डालिए, फिर ये अपने कंप्रेशन होता जाएगा और ये लेटरलाइज भी होता जाएगा, है ना। और अगर आपको ये करना है कि और भी कंप्रेशन लेना है तो यू कैन एक्सेंट्रिक ले लीजिए, फर्दर कंप्रेशन, और इसके बाद जो वेज आया उसको मन के करके, यही तो हो गया ऑस्टियोटमी कंप्लीट। इसके चलते जो आपका जब फ्रैक्चर साइट है जो कि 55 पर एंगल था वो घट के 25, कहिए कि पूरा हॉरिजॉन्टल क्यों नहीं कर देते हैं, हॉरिजॉन्टल तो करना नहीं है, हमको करना है 25 डिग्री का जो बॉडी वेट फीमर के थ्रू पास कर रहा है उसके परपेंडिकुलर करना है। 25 डिग्री क्यों, क्योंकि बॉडी के सजाइटल पेन से बॉडी वेट 16 डिग्री पर आ रहा है, बट फीमर इज नॉट ऐसे, एनाटॉमिकल एक्सिस इज 9 डिग्री लाइक दैट। सो इस पर वो टोटल 16 प्लस 9 25 पड़ता है। तो ये थोड़ा बहुत अलग अलग फीमर, ऑल फीमर्स आर नॉट द सेम, सम आर मोर वैल्गस, सम आर वेरस, लेडी का वेरस होता है, मेल का वैल्गस हो जाता है, बट 25 डिग्री दैट कैन बी 20 डिग्री ऑल्सो इन सम केसेस। लेकिन अब दूसरी बात यह है कि कितना का एंगल है, बहुत ज़्यादा एंगल है, देखा कि 75 डिग्री का क्या है पावेल्स एंगल, 75 माइनस 50, 25, 50 टू मच।
अगेन इट इज नॉट।
अब इतना बड़ा वेज निकालेंगे क्या एज पर द मोलर्स ओरिजिनल, नो, दैट विल क्रिएट अ लॉट ऑफ प्रॉब्लम। तो क्या करते हैं, देखा गया फर्दर रिसर्च में कि एनीथिंग बिटवीन 23 टू 47 वर्क्स, उससे ज़्यादा की जरूरत नहीं है। तो आजकल एक जनरल प्रिंसिपल है कि अगर 25 से 35 के डिग्री का हमने कर लिया है करेक्शन तो दैट वर्क्स। और दूसरा ये भी ध्यान रहे कि यू हैव टू कीप इट इन माइंड कि दूसरे का नेक शाफ्ट एंगल कितना है, और फिर ये देखना है कि ये जो नेक शाफ्ट एंगल हम बनाएंगे इज इट in degrees, how much more? If it is more than 15 degree more than the contralateral, chances of AVN is more. ये बात तो समझ में आ गई कि मीडियलाइज नहीं करना है, लेटरलाइज करना है। ओरिजिनल मूलर थीसिस वाज, प्रोपोजिशन वाज टू मीडियलाइज इट, है ना। But as the science developed, as the people came to know about the overall results and late complications of this operation, union was for sure achieved in majority of cases. but late complication started pouring in. 10 or 15, 20 years down the line, what happened? There was osteoarthritis of the lateral compartment. Apart from the a bit of lurch, because the offset is being decreased. Decreased offset leads to what? More abductor force to compensate for the balancing, the weight of body weight during the stance phase. है ना? तो the more abductor work, more joint reaction forces. More joint reaction forces, degeneration of the joint. So you have to try not to decrease the offset, because after, by valgalization you are already decreasing the offset. Further medialization will put the mechanical axle more medially. So effective offset will be further lessened. To offset this, you have to lateralize it. This is the modern way of doing. So पहला जो पहले करते थे, अब उससे हम लोग आगे बढ़ चुके हैं. So, और if at all आपके पास है ही नहीं, या आपके पास गलती से आ गया कि सिंगल डबल एंगल ही है, तो keep that double angle a bit बाहर, 10 to 15 degree, 10 to 15 mm, तो अपने lateralize हो जाएगा.
इसको खींचेगा फर्स्ट में, फिर यहाँ वाला स्क्रू देना पड़ेगा.
Lateralize जो बाहर ही रखोगे, तो ये तो यहाँ सट गया, अब यहाँ सब बाहर हो जाएगा, तो भीतर जाएगा ही नहीं. इसमें नहीं करना है, वो डबल एंगल में करना है.
जितना ग्राफ्ट है ना,
अब आप अपना करके
जितना सर बीज जो कट के आया उसको अंदर हम लोग ग्राफ्ट भी कर देते हैं चारों ओर से.
हाँ, भर दी.
ये ध्यान रखना है, ग्राफ्ट को
वो है तो क्या,
इतना बढ़िया कैंसिलस वेज है, that will add in stability also and in union.
The whole idea is to make the vertical angle more horizontal. How much horizontal? 25 degrees short of horizontal. After the completion of operation, the fracture line should make an angle with the horizontal of about 25 degrees. What will happen? Now the forces will act perpendicular to the fracture, leading to, this is the primary. चला कंट्रोल करिए. अभी पहले को सर्टिफिकेट देने दो बच्चों को.
Thank you, Ranjit sir. Thanks a lot for the nice demonstration of the workshop. Now we are moving to the felicitation of those who have presented their work in the form of their papers or the oral presentations, as well as the posters in both formats, e-posters as well as in the hard formats. So, first of all, I would like to call those people who have won in paper presentations. All the papers were good. All of them have courage, shown the excellent courage to present on the stage. It was good enough for everyone. Okay? But at least somebody has to win. Somebody has to be first, second, third, like that way. So going by that norm, I would like to invite for the third prize in oral presentation. And for the presentation, I would like to invite Dr. Bhuvan sir, Dr. Rajiv Anand sir, Dr. Ranjit sir to be on the stage, please, to present, to felicitate our youngsters basically. And Sudhir Kumar sir, is he here? Okay. So the third prize in oral presentation is a tie, and it goes to Dr. Birprajit Roy and Dr. Madhusudan Kumar. Both of you please come over here. Everybody please applaud him. ये भी है सर, दोनों टाई है इनका. Congratulations. And the second prize goes to Dr. Avinash Kumar in paper presentation. Dr. Avinash? Is he here? Dr. Avinash Kumar? He is not here. Dr. Avinash Kumar. Can anybody call him? Is he in the lunch area? Dr. Avinash Kumar. And finally, the first prize in oral presentation goes to Dr. Upadhyay Shubham Shankar. Upadhyay. Nice one. Good presentation. Are. Now it's time to felicitate our youngsters in poster presentation. So, third prize goes to Dr. Avinash Shah in poster presentation. Dr. Avinash Shah. And it's a tie with Dr. Zubin 9. No, both of them are tie. Third prize is... And second prize goes to Dr. Avinash Kumar. Dr. Avinash Kumar. No, same. He is not here. So the first prize for the poster presentation goes to Dr. Abhishek Madhavan. Sir. Dr. Avinash Kumar, is he here now? Not here? Thank you all of you for the great participation, all the youngsters. Bhuvan sir, please. Over to you now. Ranjit sir. Rajiv sir, please.
So at last, now it's the end of this 2 days conference. I must thank each and everyone who has really helped me to do this conference well. All the pharmaceutical partners and the media and Hotel Moria and each and everyone. And I am especially indebted to Bihar Orthopedic Association, especially the President Dr. Anil Kumar and Secretary Dr. P.K. Sahu. They have done a wonderful job. They have always supported me to go forward. So thank you very much. Thank you all the delegates and thank you all the postgraduate students. That and especially Kishanganj Medical College, they have participated in a big way. That's a very good sign. And I encourage all the PG students to come forward for the forthcoming new conferences. Thank you very much. Thanks to all of you.
I request all the PGs to be here to take the number of Dr. Ravi Chauhan so that he can add in a IATS Academy group.